Hi, Matthias. How are you?
Today I have a long surgery here.
Yeah. What do you have? What do you have on the menu?
I have a patient with a moja disease.
Oh, okay.
A young patient, 36 years old, female, with a history of ischemic attack in the left hemisphere, and I need to perform a bypass between the superficial temporal artery and M4.
Excellent. Yeah.
Yeah, in 1 hour at least. And how are you?
I'm fine. We are missing you guys to meet physically. I hope the vaccine will give us the chance to meet next year.
Oh, great. Yeah.
Wishful thinking, yeah.
Yeah.
We were saying we are not going to be the first one to have the vaccine. We'll wait 1 more month and see the results before we start.
Yeah. I can
Are
imagine.
you getting the vaccine soon, or how is it in Argentina?
We don't know, really. We have many cases every day, and I don't know when the pandemic will finish.
Because we are expecting it by January. Let's hope the best, yeah.
Yeah.
I'm seeing Pablo was there, and then this appeal, or he's with us, I don't know. Yeah.
We are hoping, expecting the vaccine here, and the government said that in 1 month, maybe the Russian vaccine will arrive to Argentina.
Okay. Right. How is the percentage of success in the Russian? You have an idea? Because I haven't heard the statistic.
I don't know. I don't know the percentage of success. No, I don't know.
Yeah. At the beginning, they said in the range of 75, but I'm sure they will excel.
75 is a high percentage.
Yeah. I'm seeing Ramesh now joined us.
Hi, Ahmad.
How are you? You look refreshed like me.
Hi, Matthias.
Hi, Ramesh. Good morning.
Morning. Well, yeah.
How are you?
Yeah, very good. I mean, you still on mask.
Pablo. Good to see you all. Vladimir apologized. He will be late because he got an AVM, and I'm sure he won't keep it for somebody else. He said he has to take the AVM is there, and he has to do it. So he said he would be late, so I might start with the session with you guys. So we will have an exciting program.
Vladimir is there.
Oh, here, Vladimir. Sure. I thought the AVM was, I told them that you grabbed the AVM.
It's here.
Vladimir, do you hear us?
I do. Everything all right. Hello, everyone.
Oh, so
Pablo,
fast to go.
Vladimir.
What's happened to the AVM?
Yes, great.
Vlad, what's happened to the AVM?
What? It's okay. It was fast and easy.
Oh, okay.
It was a medical doctor and frontal grade 1 AVM. Fast.
Oh, okay, well, wonderful.
Done for today. How is the situation?
We have a heavy rain in Riyadh. We have heavy rain in Riyadh.
Heavy rain?
Yeah.
Unexpected, isn't it?
Weather changed. We took this from you guys, and you should get the sun then.
Right. Yeah. We are freezing now. It's -3, -5 all the time. Boring.
So this is good for the vaccine, for the new vaccine.
How's London, Ramesh?
London is not too bad. We're having this on and off lockdown and restrictions to go out or to have social gatherings, but we are, it's not too bad. But there was a lot of cases outside London recently, so that's why they've imposed a national lockdown recently, which was for the last month. We were not having any parties as I used to have every weekend, but
we are locked down for 4 weeks now, even with curfew. And
I see.
strangely, as you say, in London, there is less cases in Prague than in the countryside, than in the rest of the country. Prague is doing rather well.
And there's no restriction there?
No. We have few patients in a hospital, 6 on ventilator, another 40 in the hospital, and it is the same all over the place. But outside Prague, in smaller cities, there are more cases. Fortunately, on Thursday, we are having some relaxation of everything, sports and restaurants and galleries, museums will get open.
Okay.
Some limits of people there.
Okay.
Boring.
Yeah, I know it is.
Pablo, how is Spain?
We can't hear you, Pablo.
Pablo.
I mean, he's not muted, but we can't hear him.
Probably he himself is muted.
Yeah, I think he's using a lot of technology, so he doesn't know which. No.
Right.
No, we can't hear you.
Major lockdown in Alicante because they are partying all nights.
They do. They definitely do.
You do get, Imad, you do get some floods, big rain once in a while, don't you?
Yeah. Sometimes it becomes floody, actually.
Yeah, I know.
The street will be flooded, yeah. And in the southern part of Saudi, there are usually very heavy rain. It's more mountainous.
Yeah.
The desert becomes mud then, or what does it look like? It must be flooded like fast rivers?
Not the river, because the rain and drainage system sometimes. Problem with the drainage system, yeah.
Now you can hear me now.
Yeah.
Now we hear you, Pablo, yes.
I think you changed your screen to green screen.
It was the other one.
They're beautiful, Pablo.
So the thing here is that what they have closed are the borders in between the provinces. So we cannot leave the province of Alicante, but we can go outside with mask all the time, and we cannot meet more than 5 people at the same time.
Oh, okay.
That's the main thing. And the restaurants and business, they close at 11 p.m. and at 12 p.m. nobody can go outside.
Yeah, it's fairly similar here as well.
Similar. But restaurants closed. You have restaurants open in London?
Restaurants, I mean, during this lockdown, which is going to end tomorrow, nothing was open. But from tomorrow on, after tomorrow, they will open. But there is some strange rules that you cannot sell alcohol unless it is accompanied by a substantial meal. So so there's a lot of discussion as to what constitutes substantial meal is.
Crisps.
Crisps is not going to cut it. So you need to have a good meal to go out.
We had a restriction that restaurants could have sold things through the window.
I agree.
Yes.
But no alcohol allowed on streets.
Yeah.
You cannot get a beer on the street, nothing.
So that's
Andre, how are you?
Andre.
He's muted, I think. Oh, he muted himself.
Andre. You know what's funny? My father got it for the second time. He's now COVID.
Is it possible?
positive.
Really?
Oh,
Yeah.
Yep.
He's still asymptomatic in his 99 years, but he's positive now for the second time. First time in April and now.
But did he have
Victor,
antibodies?
hi,
Did
Victor.
he get antibodies?
He did.
Oh, that's
It's
so
probably
unusual.
dead virus what he has now. I don't know.
Okay, very likely.
Very likely, yeah.
Andre is taking a beer or coffee?
This is well, I know in Czech they have this dark beer. No, this is my espresso.
This is dark beer.
This is a double
Espresso.
espresso.
I thought it's a
Guinness.
black beer from Prague.
Guinness.
Or
I
from,
think
Yeah. Krusovice.
Hello, everybody.
Victor,
Good to
how
see
are
you.
you?
Hello, how are you?
No, Victor.
This is coffee
Yeah.
with a brain.
We see the brain, but we don't see the content.
By now, Victor, you should have made a cup the size of a skull and drink from it.
Yeah. Yes, of course. Yes.
A small
So
cup.
how is the weather, Andre, in Holland?
Well, it is gray outside, foggy, and some rain.
Okay.
So same as London then, Andre.
Yeah, I would say so. It is very similar. I know that there is not a big difference. No, it is sea climate, so that's November typically not well. It's 1st of December, but that is it's more rainy, and but it has already.
This is the worst time of the year, you know.
Yeah,
Dark at 4 p.m.
But it's
Dark
already
until 8 a.m.
Below zero now. It is for a couple of
Is
days.
that
It's
freezing?
below zero. Giovanni is also
Giovanni.
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 Hello.
Hi, how are you?
I'm fine. I'm fine. Imad, I have a little problem. At 4:30 p.m. Italian time, I have to leave because I have.
No problem. We will cover.
Okay. Thank you so much. Everything is fine.
So far, so good. I'm seeing you already ready to go with the suit and the tie.
Yeah, you know, I'm very ready to go.
Ready, yeah.
Yeah.
But later, not now.
Well, you can invite the group with you. I mean, but we are far away.
Yeah.
Okay. Hello to everybody. Hi,
Kohn,
Vladimir.
how are you, Kohn? Dr. Kohn, how are you?
I'm fine. I'm fine.
Hello,
Good.
Takashi.
Yeah. Good evening, everyone.
Good
This
evening.
time also.
Good evening.
Yes. Good to
Evening.
see you.
Time also prepare.
You already quite a number of attendees, so that's very good.
We have 2 more minutes, I think, Pablo, yeah?
Yes, and the thing is that YouTube is also open. I shared by email with everyone the YouTube channel.
Okay.
I will do it again now. So there are 80 people right now here, and in YouTube, let me see, we have 10 people. Yeah.
Yeah. Oh, nice. Very good.
Yeah, that's it.
Okay.
And the thing is that YouTube is also open. Done. I shared.
Sorry.
Jo, díky, tady. Máte. Díky.
So I think I will proceed. Well, welcome everybody, attendees from all over the world, from the, I think 5 continents. I didn't see anybody from Australia. Hope there were some. I'm seeing Dr. Moody join us. Hi, Moody.
Hi, Matt. How are you?
Hi, Moody.
Fine.
You,
Hi.
Pablo,
Okay.
Matthias.
Well, it's my pleasure to introduce the faculties. We have 2 sessions, one today on CSF and NPH. They will talk about CSF physiology, anatomy, and shunting, hydrocephalus. It will cover the whole aspect of this. And we thought, since we are talking about CSF, there will be a session on NPH by Dr. Salman Sharif from Karachi. This is an inauguration session today because this is the last of the series of 2020. I'd like to commend and thank all the members and invited faculties for the past 7 webinars, 6, and this is the 7th. And we hope we will continue these activities in the upcoming year, pending the situation with the opening with the COVID-19. If we manage to get the vaccine, all of us, and we will be able to greet ourselves, hug each other, and have a toast together to reunion physically in a meeting. And I will leave the venue. We have 8 presentations, and we appreciate Vladimir and myself that you will be on time. Some of the presentation, they don't need a lot of discussion. One of them, Ramesh, yours doesn't need a discussion. We all get it for granted that the history you are giving us, we will accept it. But others, they might need some discussion. We try to cut it short because we don't want to stay overnight or after midnight in Japan, for example. And I leave the venue for Professor Benish. He will be chairing this session. He is the chair of the neuroanatomy, and he will chair that session with Dr. Giovanni Bocci from Milano and Dr. Victor Lopez from Mexico. Vladimir is yours.
Thank you, Imad. I believe that the first thing is to pass the thanks to you, because you thank the faculty, but I believe that the greatest thanks should go to you, because you all over the 7 courses, you have got the best teachers, best lecturers, and you did a real great job. And I believe that the 7 is not the final number, that we shall be meeting and seeing each other in the 2020. And I believe that soon I shall be able to invite you all to the lobby to get a beer, because this way it's really a little abstract. So let's go ahead, because we really do not want to keep East Asians through the midnight. So Ramesh, the floor is yours for the second part of the history of neurosurgery, please.
Thank you, Vladimir. And I do echo what you said about the whole webinars organized by yourself and Imad Kanan. And also we will take up your offer for the beer at some point in future. I'm going to share my screen. If only Pablo could let me do it. Okay, so I'm going to share my screen now. So this is the second part. Prof. Kanan asked me to focus on the hydrocephalus, which we'll spend some time on here. We have, in the first session, we have gone through the various epochs in the history of mankind when people started thinking about the brain and the anatomy and started doing dissections. We segregated them into periods when Hippocrates was around, and then the Alexandrine period and subsequently Roman Empire. And I could not finish the last session with Galen, who is the famous anatomist. So I'll go on to describe his contribution, then we'll quickly go through some of the other important personalities. I'm not planning to talk on the more recent one, because people like Cushing or Hadanti, they will need a session for themselves. As you know, Galen was the pioneering anatomist who did excellent work on the anatomy in general, and he, in the era of 129 AD to 200 AD, he is from an area called Pergam, so that's why he's called the Galen of Pergam. And when he was in his studies, his father, Nikon, thought that maybe we should send him to study philosophy and other things, which was more in vogue at that time. But Nikon had a dream from the god of medicine that he should send your son to study medicine. So then he changed his mind, and at the age of 16, Galen enrolled in the medical school in Pergam, which was the second best school in that time, because the first one was in Alexandria. And so then he studied for 4 years, and then subsequently after that he left Pergam to go through various different countries and learning various things about human body and anatomy and medicine in general. Then he returned to Pergam, and when he returned to Pergam, he applied to become the chief physician for the gladiators. And the chief priest at that time put a challenge forward for all the applicants, for the gladiators. The priest eviscerated an ape and put it in front of them, asked them to heal that ape. Nobody took that challenge up, but Galen, with his excellent knowledge and wound caring, he took up the challenge and became and saved the ape, and became the chief physician for the gladiators in Pergam. So this was his first experience in terms of healing major injuries of the body, and he often described the wounds as the window to the body. And in that time, only 5 gladiators died, whereas the year before him, 10 gladiators died. So, he only in that time only 1 died, and then the year before him, 10 gladiators died. So that accounts to his ability to heal and his the careful nature with the wound management. And then his magnum opus is the classic, and you can see various scenes from the time around this picture, the treatment. And at the bottom picture, you can see a pig being dissected. So then after that, after some time, he left to Rome, and then started teaching. And here you can see in the Temple of Peace, he was teaching the students about the anatomy, especially the anatomy using animal skeleton. So eventually the fame then spread around, and the emperor at that time, Marcus Aurelius, some of you might have read this book called Meditations, which is a key book in Stoic philosophy. He took his great personal physician, and he served some of the emperors at that time. So this is his famous experiment where he cut the vocal cord of the pig and found that the led to hoarseness of voice. So many things he described, and many of the things we as neurosurgeons know, he described the interventricular foramen. We call it foramen Monro, but Galen described it in 200 AD. Only we put the name of Alexander Monro only in the 17th or 18th century. And he described the pineal gland and the infundibulous stalk, pituitary, and the meninges. So many, and also the 4th ventricle. And because we didn't know the physiology behind all this, so the people, and especially Galen, thought that these ventricles contained the spirit, animal spirit, which then directs the various organs of the body. He also made some contribution to hydrocephalus, which I'll come back to later. So then we will go on to Paul of Aegina, who is another famous physician. He wrote books. He had 7 books to his credit, and he also described hydrocephalus, which we'll talk about. But the main contribution to him was he was an innovator. He devised a lot of surgical instruments. If you see those instruments, we'll know that some of the designs were still carrying on till today. So we're talking about 600 AD. And more than that, he influenced a lot of Arab physicians who came on later to impart this sort of surgical knowledge, especially Albucasis. And then when the School of Alexandria then got destroyed, the Arab physicians carried on with their work on the human anatomy. So for the next era, we go on to the Arabic medicine. A lot of great personalities and physicians there, especially Raises, or Ibn Zakaria al-Raisi, was a physician, but also did a lot of work on surgery. So his influence on surgery carried for a long time. And he also was the first to describe concussion, and also talked about hydrocephalus and also on head injuries. Then we come to Avicenna, which we all know about. His greatest contribution was the Canon Medicinae, and also he translated the works of Galen, which is probably thought to be his biggest contribution. This is from one of his books, when the picture shows an Arab physician treating a spinal injury. So then comes a very famous scholar at that time, Albucasis. He is known by the name Abu al-Qasim al-Sarawi, but we know him as Albucasis. Here you see him treating a patient in a hospital in Cordoba. But the greatest contribution, as you can see, he was a scholar of par excellence. He wrote this book, Kitab al-Tasrif, which ran into 30 volumes. Can you imagine that in a lifetime, somebody doing a book which ran into 30 volumes? The method of medicine, which is influenced subsequent medieval Europe and Western medicine for a long time. He also described many things, including surgical instruments and non-sinking trephine, and also talked on hydrocephalus. He also was to recommend treating it with drainage, and also put these kids on a dry diet and also bandage their head with some variable results. And then we go on to the medieval Europe, and this was subsequently the Constantine the African, who was in this 1000 AD, carried on with this Arab medicine, and they brought several books from the Arabic world to the medieval Europe. Because he studied in Baghdad, it is said that when he traveled, his ship was broken, and then a lot of his books were lost, but he could salvage some book, and subsequently all this knowledge came back to Greek. And he did do some dissection, especially starting with an annual dissection of a pig. And sorry, let me just move it back. So he then, in that era, a few others, Roger of Salerno or Theodoric Bogani, and there's so many famous physicians and surgeons there. And the one person I would pick out is Guy de Chaliac in AD 1298. And he was the physician to the Pope at that time. You can see here he's bandaging the Pope Clement VI at that time. And he also wrote a surgical textbook, and that influenced the next 200 years of surgical knowledge. And he's the one to insist that surgeons should learn anatomy, as we all know now. And he said, surgeon ignorant of anatomy is like a blind man carving a wood, which is so true. Then if you go back to the next century, on the 16th century, this is when the major things happen. It's the age of Renaissance, and we know about Leonardo da Vinci, who is a polymath. When you say polymath, there are many people in this Renaissance age with so many, they are genius at many levels, not only the drawing or the art or anatomy or physicians and philosophers, they are combined into one thing. So they were so brilliant. And Leonardo da Vinci, you know him for the famous work in Mona Lisa or Last Supper, but we know him for his anatomical work. He did excellent drawing of human body by dissecting it, cadavers, and also describe ventricle. We will come to that later. So then we go on to, sorry, let me just go on to the Ambrose Parry, who's a famous surgeon, served the King of France, and he was from a poor background, but served a lot of time in the military and gained excellent knowledge of the surgical conditions. And when Henry II died from a head injury, he postulated that he died from subdural hematoma, possibly from a torn cortical vein. I mean, you can imagine he made that diagnosis from clinical observation. A patient had headache and drowsiness and slurred speech and labored breathing, and could not save him. But at the autopsy, he was there, and he was right, from a subdural hematoma from a torn cortical vein. So these were great physicians and surgeons at that time. The two persons I would mention separately is Berengario di Carpi, who made the first complete discussion of ventricle, and also the Johannes Dryander, who we could say that produced the first textbook of neuroanatomy. Then we come on to another person here, Giovanni Andrea Croce. The pictures and the drawings were exquisite because he drew this neurosurgical scenes in noblemen's homes, like in a bathroom or bedroom. You can see the kind of scene where they do the surgical operation. The trephining is going on in a bed, and there are servants to bring out all this. You can also see a cat there in the scene. And also in the scene, you can see it's being done in a bedroom, and the child watching it, and the family is next by. So this is a kind of scenario in those times when people used to operate. And when we go on to the then before, I cannot stop the 16th century physician without talking about Vesalius, who dissected human bodies, and he said it is easy to get the human bodies, especially the heads of criminals after they get executed, because the only thing you need is some good company with the judges and the prefects, so he could obtain the heads in a fresh manner, and then he could dissect it. So seen from his dissection, he is the one who first said that the dissectors should be teachers. So it cannot be just prospector. In those times, people used to ask others to dissect for them, and then they watch it and write it down. But he said there should be the dissectors, that they should, it's like a teaching. So you can see the whole scenario here. People are watching his dissections. Then we come to the next century, who in the 17th century was a century of where the neurology really developed, and the main person was Thomas Willis at that time, who also an anatomist, Oxford graduate, then came to London to practice, and we know him for his work on the vasculature, and he described the circle of Willis, and in this book Cerebral Anatomy, and this engraving was done by his good friend Christopher Wren. Sir Christopher Wren, who also was a famous architect, and you know him as a designer of the St. Paul Church here. And he also described the choroid plexus of the ventricle. We'll come to that soon. And then the other famous surgeon was Humphrey Ridley, who wrote this book, made a lot of discovery. In fact, his description of anatomy was even more accurate than Thomas Willis. So this is the picture from his book, and it shows the accurate anatomy even better than Thomas Willis. So then we go on to the 17th century. We talked about 18th century. Then there are so many English neurosurgeons. Percival Ford, we know him as the first modern neurosurgeon because he made such a contribution to neurosurgery, devising new operations, describing various conditions such as Port disease and Port sepsis, etc. And John Hunter, who we more know from his vascular work, and we also have to remember these persons, Benjamin Bell and Morand, and Domenico Cotengo also described CSF, which is interest to us. And then we go on to the next century. You can imagine, until that time, we didn't have antisepsis anesthesia, so the surgeon has to be really fast and very precise. So that's what really counts. You got to be, for example, if I tell you about we just sort of digressing here, and this is Robert Liston. Just tell you an interesting story about Robert. He's a Scottish surgeon, practiced in London, a very famous surgeon, very popular. Patients used to queue before his practice to have consultation. He was the fastest surgeon. He used to, these are the knives he devised, called a Liston's knife, and very sharp. And you can see the scene here from his theater. As you can imagine, operation theater really means theater. There is an audience around it, and he's holding on to the thigh, and he's going to do the amputation, and people are holding on to the patient. So you got to be really precise, and because there is no anesthesia or anything at that time. And there's one incident where, which is actually a true incident, where he did the amputation. Normally his words to the audience is, "Time me, gentlemen," before he does the amputation. It's apparently the best time is 8 seconds for amputation. And he did an amputation, chopped off 3 of his assistant's fingers along with it. And also when he took the knife out, the knife caught the coat of one of the old elderly spectator who got the shock of his life. He thought he was injured, and he died of heart attack. And the assistant, of course, died of infection and gangrene, and the patient also died. So that was a very unusual incident. That's the first operation with the 300% mortality, but otherwise he was a brilliant surgeon. But these are things which used to happen at that time. And then when we go on to the localization, we know about all these great surgeons like Charles Bell, and Crevelier, Paul Broca, we know he explained localized the anatomy of the speech area. And that is based on Overton's patient. Overton had a patient who shot himself with a gun, and then the frontal area was damaged. And so Overton used to poke a stick into the wound to put pressure on. Then he described it, saying that if I put pressure on the frontal lobe, the patient gets a speech arrest and all that. And remarkably, and lower down here you can see Bartholow, Robert Bartholow. He had a patient, very remarkable patient, who lost a lot of skull, and so he had a patient to check all this. And so he used to put current, like an electric wire, and he used to say that when I put the current, the patient stopped speaking and patient has teaching of. So that was unethical at that time. It is, you can say it's unethical, but he sort of experimented with all these patients to advance our knowledge of anatomy. And for the sake of time, what I will do is to go on to some literature about the our topic of interest, which is CSF. Let me just get back to it. So here, sorry, 1 second. Right, and I will probably skip it for next time. There's a lot of discovery from this time, including Hosley and Cushing and Dandy. But I will just give me 5 minutes to talk on our topic of interest, which is CSF. So Aristotle was the first one to recognize that there is ventricles and there is a hole in the center of brain in most animals he studied. And he then described the ventricles, but it's mostly the next era in the Alexandrian period where Hierophilus, who we consider the father of anatomy, and his younger colleague, who was Erasistratus, which we talked about last time, with the story of him treating King Seleucus' son. So Erasistratus was the first one to describe ventricle in detail, and he said it contained animal spirit. Then that was carried on by Galen, which then propagated for centuries. Then who else? Then Rufus of Ephes. He accurately described the ventricles in details, and he was the teacher for Galen. And who else was then responsible for the? Sorry, who else was responsible for? So at that time, the theory was that there are 3 ventricles, and each part of the ventricles contain function for different parts of our body. For example, the frontal horn for fantasy and imagination. If you get damage to the frontal part of the ventricle, you get impairment of that system. In the posterior aspect, you get memory impairment, and the middle part you get the logical reasoning. This is a kind of a tricameral system which then carried on for some time. Then it was subsequently challenged by Da Vinci and also Vesalius, who then refuted that idea. But Da Vinci's writing, you could see the ventricles were described, but he didn't have the occipital horns. So you can imagine the bodies were not then in good shape, and when he injected the wax to demonstrate the ventricles, the temporal horns were not filled up. What he used to do is to inject molten wax through the 4th ventricle into the ventricle, then take the brain away, and then describe the ventricle. So, but it's quite anatomically accurate given the kind of knowledge we had at that time. Vesalius again described ventricles, and he also described the 2 patients with hydrocephalus. In the book 1, he said he described a patient, a young child with the size of the head of 2 men. And also in the second edition, he described a young girl with a large head. He said the patient had head larger than any man's head. And eventually, the autopsy was there, and he found that the fluid was actually within the ventricle, not outside, as which was thought before. So then there's one remarkable man, Casseri, who did excellent drawing of the anatomical specimen. You can see the kind of drawing. The cadaver is sitting with the muscle being pulled out to explain it, and also he's the first one to describe arachnoid granulations. But then it was further described by Pacchioni, who's in his dissertation, and we know this Pacchioni granulation in his name. Then we gone to Thomas Willis. As I mentioned, he described the choroid plexus, and he's the one who said the CSF is coming from the choroid plexus, not from somewhere else. And there was a hypothesis at that time by René Descartes, who is a famous French philosopher. He said pineal gland is a very important organ regulating the flow of animal spirit. He said the pineal gland moves like a valve to direct the animal spirit to one part and the other. But this was subsequently refuted by Neil Stenson, who said pineal gland cannot do that because he dissected the pineal gland, found that the pineal gland is very fragile thing, hasn't got anything to move, so he refuted that. And then we also know cavum. We see in cavum verge, and this is by Andrea Verge, who is the Italian professor of psychiatry, who described this cavum. The final ventricle, the fifth ventricle, described by Stilling and subsequently by Fedor Cross, who is a German surgeon. And sometimes we use the fifth ventricle to give the term Cross's ventricle in his honor. So that is, finally, the whole idea of CSF coming from being regulated by the pineal gland, everything was refuted by Magenti, who described the foramen of Magenti. And
25 minutes.
Yeah, so I mean, this is probably the last slide, Vladimir. So you can see he described the foramen Magenti, and by that time we know about the ventricular system. There were at some point people describe at least 8 loculations, but we now describe about 5 ventricles. You know, the lateral ventricles and the third and the fourth, and also the fifth ventricle. So this is how the history of the ventricles, as Prof. Imad requested me. I think I'll stop here, Vladimir, for you to carry on.
Okay with you.
Okay, stop sharing.
Are there any questions? One or two questions, except of chat, please. Ramesh, you will reply on a chat.
I will do.
Please, and if there is some question just now.
Yeah. I will also, I mean, at some point we should, we can have further discussion on, like a single session on big, great anatomists in the recent past. I mean, in the 20th century.
Yeah, good idea. That we can have as one session. Imad?
No, nothing on chat. The only thing, they were praised for his presentation, I have to say. Thank you.
So, just thank them, Ramesh, please.
Thank you all.
So let's go to the other lecture, which is Aib Cherian, whom we all know very well, and this is a guy with always unorthodox thoughts and some new insights. So Aib, I hope you will keep your mode. So please.
Thank you, Vlado, all my friends. So good to hear you, so good to see you, so good to hear from you. And I hope this nonsense of seeing virtually comes to an end, truly. And I'm sick and tired of this right now. So I hope we see very soon. I'm starting my talk. And to thinking to talk about, and then I thought I will tell you a small story of how we evolved. Can you see my screen, everybody?
Yes.
Yes.
Okay. Right. So this is CSF New Perspectives from us. Now, first thing what I wanted to tell you, mind is the biggest lab. So without any doubt, all the people that we have talked about, Leonardo da Vinci, everybody, they did not practice evidence-based stuff. And most of the biggest discoveries has been done in that time. Because the mind was the biggest lab at that time. Today we don't use the mind. Most of the guys don't use the mind. They use big, huge infrastructures as labs, and therefore, our breakthroughs are not very good. So always remember, for the young neurosurgeons, I should tell you, mind is the biggest lab. Now I'm going to tell you, back in 2007, I made a mistake of misunderstanding a patient of trauma for a patient of aneurysm. I will not tell you how it happened, but in a patient of trauma, I thought it was an aneurysm because there was a switch in patients. And I went ahead and opened all the cisterns and looked for the aneurysm for a couple of hours and could not find it. And when I panicked, I asked my assistant, I cannot find an aneurysm. And this man told me very nonchalantly that this is the trauma patient. So I was angry. Of course, I told him things which I cannot translate for you right now. But the end of the day, what happened is the brain was very lax. I saw that there was a severe traumatic brain injury. And I saw the scans. I had seen the scans already. And that is where our journey began, way back in 2007. The first thing I thought was, if I opened the cisterns, the brain was getting lax. I treated the trauma just like an aneurysm, and things changed. Then I started thinking why that happened. Because I did not know, if I drained the CSF, how did the brain go lax? I did not know. So I had to figure out how that happened. So then we thought the CSF at the base of the brain is probably communicating with the brain. Why we thought that was because we understood that we know whether we believe in God or not. You must understand that the human brain is one of the most magnificent, there are no words to describe it. It is one of the most magnificent creations on earth. Its cooling system should be magnificent. Its cleaning system must be magnificent. So the CSF, if we think that the CSF is just there to float the brain on, it's a completely stupid way of thinking. So I started thinking that the CSF is changed every 3-4 times a day. 3-4 times the CSF is changed. Why would the CSF be changed 3 to 4 times a day? The only reason why somebody would change CSF 3 to 4 times a day if it's getting dirty. If something is happening to it, the constitutions are changing. So I thought there must be some way the CSF is communicating with the brain. This was way back in 2007, and G-lymphatic system was not there at all at that time. So then I thought, if the CSF is getting inside, in trauma, there was an accelerated process of CSF getting inside. That is why I thought that you have trauma and 2 hours later, you don't see any cisterns. You see, there are 120 ml of CSF at the base of the brain. And this 120 ml of CSF, how can it disappear 2 hours after trauma, severe head trauma? Take a scan, no cisterns seen. Where is the CSF gone? So some of the neurosurgeons that I know, they told me, oh, that is easy, the brain is compressing it. I immediately understood that they didn't know the basics of physics. If you take 100 ml of a bottle, something like this, try to compress it, it's impossible. The whole science of hydraulics is based on that. Its fluid cannot be compressed so much. It will take tremendous amount of force. So those guys did not know their physics. And, you know, as neurosurgeons, we are not expected to know much physics, but we should know the basics at least. So I thought, no, this is not what is happening. So where is the CSF disappearing? Somebody told me it is gone to the spinal canal. That was again impossible. Imagine 80 ml of CSF going into the spinal canal. The pressures would be so high that the spinal cord will infarct. So where is the CSF going? The CSF is obviously going into the brain. And that is exactly why you have a very, very tight brain and no CSF seen. So then I had to figure out how the CSF is going into the brain. So I started looking at every single possible way. As Vlad told me, I was unorthodox, you know. I never listened to anybody. I mean, whether that is neurosurgery or whether it is life, I generally don't listen to anybody. I have my own ways of looking at things. So I started looking at all the papers and I figured out that there are these interesting spaces around the vessels which communicate all throughout the brain. And these spaces are called Virchow-Robin spaces. And I thought, CSF must be going in through there. Now, there were some papers which said, if you inject something into the system, it doesn't go into the brain. And these guys were injecting markers which were huge. And imagine if you have a door, this is my usual example. If you have a door and if you say the elephant doesn't come through the door and you say the door doesn't exist, that's stupidity. So I understood that the CSF goes in to the brain, and the CSF definitely goes into the brain in trauma, and that is how we described CSF shift edema. So this was the CSF shift edema that we described. We got it published. It is now, these are textbook chapters, these are papers. So this is the CSF shift edema is well known now. A lot of people don't agree with it. They will eventually agree, but this is what is CSF shift edema. And then we started thinking, why does the CSF go in at all? Other than the CSF shift edema, why does the CSF go in and at all into the brain? Then we thought about the fact that the brain is probably a water-cooled and water-cleaned system. But by that time, G-lymphatic system was out. The theory of G-lymphatic system was out. And we knew that Nedegard, Illiff and Helene, they had described this, and I was in communication with them, and I was amazed to see what I was talking in 2007. I had no evidence of that, and this was proven by basic science. It was proven that CSF goes in. Now the question was, why does the CSF go in? So we figured, how does this, we started thinking, how does the CSF clean and cool the brain? So it has to be two different pathways. The first pathway is the cooling of the brain by CSF. So you see, what we proposed was crazy. You see, there are these huge sinuses. You have the maxillary sinus, you have the sphenoid sinus, you have the ethmoid sinus, you have the frontal sinus. And in the epicenter of these sinuses, you have the suprasellar system. And what exactly are sinuses? They are spaces, large cavernous spaces lined with wet mucosa. And it is like, you know, these are like sweaty t-shirts you wear. Imagine you are very warm and you're sweating. And you go sit under a fan. What is the fan here? The fan is your breathing. When you are breathing, what happens is the air circulates through all these sinuses. It's amazing, but the air circulates through all these sinuses when you're breathing. And what happens? Because of this air circulation, the mucosa, it evaporates faster. It is like putting your clothes to dry in front of a fan. I'm sure many people have done this when you're living in closed rooms, you know, in dormitories and all that. We put a fan to dry our clothes. Exactly what is happening. But here, what happens is, when this mucosa evaporates because of this air movement, it becomes cooler because the latent heat of evaporation is given off. That is a principle of air conditioning. That is a principle of every cooling device. So what happens is, the mucosa which lines these sinuses, they are like an air conditioner. And the epicenter of it is the suprasellar cistern. And the suprasellar cistern is cooled. Now you have 2 to 2.5 degrees cooler CSF in the suprasellar cistern. Now, how does this go into the brain? That is also very interesting. Because the Varsho-Robin spaces, they are around vessels. I went to tours and I went to Leonardo da Vinci's museum and I saw something called Archimedes screw. Same principle. When a vessel is pulsating, it is a wave, like a screw being turned. Same thing. A screw being turned is a wave. A vessel pulsating is a wave. So when a vessel is pulsating and it is in contact with the cistern, which is cooled, the cooled CSF is pumped into the brain by the pulsatility of these vessels. Exactly what this is. This is the diagram that we drew. So imagine the sinuses, by letting out, by evaporating because of the air circulation, when you are breathing, is cooled. That cools the suprasellar cistern, and that cooled CSF is pumped into the brain by the pulsatility of these vessels into every single square millimeter of the brain. Imagine what a beautiful cooling system this is. Now, cleaning. Cleaning is separate. It happens only in the night. So for that, you need to have contact with the ISF of the brain, interstitial fluid. And because of the blood-brain barrier, that's not possible all the time. So in the night, when you're sleeping, that is what G lymphatic system talks about. Aquaporin 4 channels open up. And then the CSF goes, that gets in contact with the ISF, cleans all the chloride, lactate, and all the metabolites. And in the morning, you're fresh. After your sleep, you're fresh because all these metabolites which build up, because the brain is a metabolic computer. It is not an electric computer. It's a metabolic computer. All these metabolites accumulate. And these, when you sleep, what happens is these aquaporin 4 channels open up. CSF goes in, collects all these bad molecules, metabolites, and it cleans. So the cleaning pathway is separate. It happens in the night. That's why sleep is so essential. And cooling happens all the time. Cooling is, the cooling tubes are not in touch with the G lymphatic pathway. Your Varsho-Robin spaces are not in touch with your ISF, but it's all over the brain. So cooling happens all the time. Cleaning happens in the night. This was mind-blowing for us. Just the idea was mind-blowing for us. So we got it published in many papers and as textbook chapters in Springer Neuro Series. And now we've been, it's featured in Nature. It's featured in Scientific American. So this is the picture that the sinuses are cooling, suprasellar cistern, which is cooled, and the Verschoven pathways. This is the original picture that we drew, and it is there in all these textbook chapters. So now, what are the future directions? The future directions, we figured that when the pulsatility of these vessels are affected, in Alzheimer's, if you see, the pulsatility of these vessels are affected. And when the pulsatility of these vessels are affected, cleaning as well as cooling is affected. And heat shock proteins lay down neurofibrillary tangles. And the Verschoven spaces, if you see, in many neurodegenerative diseases, you find that the Verschoven spaces are blocked by amyloid. So maybe if we could figure out a way to have an effective cooling, maybe I might design a cooling helmet, and probably that might help. Or I might design something which can cool the brain from within the sinuses more effectively. Maybe we can do that in trauma patients and see, instead of completely cooling the whole body, if we could probably design something that could cool just the brain by the same mechanism. Maybe 10-degree saline circulating through a device inside the sinuses, and maybe we should see what happens. So the future is, there's a lot of possibilities, amazing possibilities. This is what we have hypothesized. Some of it has been proven, some of it will be proved, but this is what we have done when it comes to CSF. So I would say it's not a small contribution from our Mind Lab. So thank you very much for listening. Any questions? If you have, please.
Hype. Thank you very much, and thanks for keeping the time. As always, very unorthodox and very, very interesting. I believe that there will be rather a lot of questions and lots of criticism as well, but that's okay. That's the progress. Well, let me now invite my very good friend, Andre Groten, with whom I've spent nearly half of my professional life discussing and talking and chairing WFNS for a while. And Andre is an excellent teacher. He is one of the best I have ever met. So, Andre, talk about the shunts, talk about the selections, and please keep the time.
I will do my best, Vladimir, and thank you for this introduction. And indeed, it is great to see you, but still, I hope we will meet on a beer in Prague or anywhere else in person at hopefully the near future. It was always great discussing with you. So I start sharing my screen. Imad has asked me to talk on shunts. Let's see, that's here. Yeah. You can now see my screen. Yes. Let me check if it will start. Yes, you can see it now. Yeah. So he asked me to talk about the shunts and the shunt materials, and also how to select the right shunt for the right indication. Well, I think this should be straightforward for most neurosurgeons, and certainly for residents. I don't know. Let's see. Ramesh didn't mention this so well, but let's say I can briefly and very quickly tell about the history of the shunts. This is from a journal in 1951, so nearly 70 years ago, stating that at that time, the most popular procedures were the ventriculostomy of Torkelson and the open third ventriculostomy of Dendy for obstructive hydrocephalus. And for the unobstructive, the communicating hydrocephalus, it was the coagulation of the choroid plexus. But in that article, for the first time, they mentioned that there are now ingenious methods for shunting the excess of CSF from ventricles or spine to another space. And that's true because it was in 1949 when these two neurosurgeons, Eugene Spitz and Frank or Francis Knowlson, implanted the very first ball and cone valve system in a hydrocephalic child. So it was in Philadelphia, and Eugene Spitz went on with this, but Frank Knowlson became chair of the Case Western Reserve University in Cleveland, so he moved out later on. But that was one, but they had a lot of technical problems with that. There were bleedings, there were these shunts clogged all the time, they needed revisions. It was quite some, and they had embolisms, so it was a difficult procedure. And it only changed when this man, John Halter, and his wife, Claire, had a child, Casey, a son, who was born with spina bifida, quite severe thoracic lumbar type with myelodysplasia, and developed hydrocephalus. And he came under the care of Dr. Spitz in Philadelphia. And they did punctures of the soft spot, what was very typical, just to drain always the high pressure. And Dr. Spitz explained to him that there was a possibility to put in a drain, but also explained the high risks of that procedure of that time. And that set this man, who was a mechanic, he was not a doctor, was not even medically educated at all. And he developed a slit valve mechanism from polyvinyl chloride, very similar to the nipple of a baby bottle with milk, that when it is very small, only little milk comes out, and if it is larger, some more come out. So he developed that slit valve, but then they realized that polyvinyl chloride cannot be sterilized because of the high temperatures. This would completely deform. So it was working, but it didn't work out well because it could not be sterilized. And then he came in contact with the Dow Corning company, who had a new material, silicone, and they provided that to him for free, some catheters, tubings of silicone. And he started to do the same with this new material, silicone. But unfortunately, Casey's condition deteriorated, and they couldn't wait. So he was just a week too late, finishing his silicone shunt. Casey needed, because it was more than daily, fontanelle punctures. And so he received this ball and cone Spitz and Knowlson devised catheter. But during that surgery, he had severe complications and was left with severe brain damage. Later on, and 2 years later, during a revision, he received the shunt of his father's, but he died nevertheless a few years later of the complications of that brain damage. So this really changed, and John Halter worked on, and he founded a company. He wanted to have this not available only for his son, but for the whole community. And indeed, as you know, the Spitz-Halter shunt, one of the first types, is actually still available. And he developed a lot. He became the CEO of a large medical company. So this was more than serendipity. It was willingly doing something out of your even scope of knowledge, just out of despair. And this was the typical way of surgery. It was above and behind the ear, and then to the vena cava, the caval vein. That was a typical procedure of that time. And between this first implantation in 1956 and let's say the next 5 years, more than thousands of these shunts have been implanted. It's very odd to see that that history sometimes repeats itself, and that is the story of the famous author Roald Dahl. He had a son, and a very young son. He had 2 daughters and a son. And in 1960, while they were walking on the street, they wanted to cross the street and were hit by a taxi. And little Theo, 4 months old, was severely injured. And he developed a post-traumatic hydrocephalus. So we received that shunt, the Spitz-Halter shunt. But it clocked several times. So in the first year, he had 7 revisions. So he wrote to his mother in England and said, there should be better shunts that are not so easily clogging. And she wrote him back and said, well, we have here in England a shunt called the Pudence shunt. That was Robert Pudence, who developed also a slit valve system. It was sent to the US and it was implanted. But unfortunately, that also clogged and needed a revision within a month. So Dahl started to work with a toy maker, Wade, and a young neurosurgeon, Till, and just on their drawing boards and in their house, they designed a shunt. And they managed to do that. So they patented it, actually, and it is the Wade Dahl Till shunt. It has been implanted in over 3,000 patients. And this lower image here, you see the Wade Dahl Till shunt that was explanted in an adult more than 30 years after primary implantation as a child. And it, because of that, at that time, it didn't function anymore, but it did well. So if we look to that, we see in those years, that is 70 years ago, 65 years ago, initially Spitz and Olsen had this ventriculocaval shunt. After that, first came the ventriculopleural shunt. And just a year after that, the ventriculoperitoneal shunt became available. So in 1955, it was another kind, not ball and cone, but slit type of valve that was devised by Halter, but at the same time, a little later actually, by Robert Pudence. They improved that to either being a proximal or a distal slit valve, and at that similar time, 1959, finally the diaphragm valve was developed. And it took another 10 years, and then the first lumboperitoneal shunt was ever inserted in the human. So very briefly, the history of that. To be honest, at the moment, and probably that's already not true anymore because it goes very quickly, but there are 249 different shunt systems available in the world. And altogether, they have 486 pressure settings. So what we can learn from this is simply the perfect shunt does not exist. And because of that, many neurosurgeons say, come on, it doesn't matter at all. It doesn't matter what kind of shunt you do. You can put the Chabra shunt or any other type of shunt, it's all the same. And to be honest, there is only one really randomized study comparing different shunts with each other. And now we have the developments from the usually fixed settings that we always had versus the now programmable, adjustable systems. Still, with everything what we do, over drainage is the biggest problem. And with over drainage, also obstructions and so on. From this one study, actually, they say the gravity-assisted valves that now have come into the market about 15 years ago seem to be superior to the other ones. But nevertheless, if you look in a single institution, the choice of shunt that they use is very often industry-driven and not based on any physiological parameters of the patient. So let's look to the system components very quickly. We all know this is basic stuff. So you have a proximal catheter for the inflow of the CSF, then you have also a distal catheter bringing it to some kind of cavity in the human body, usually the abdomen or the heart, but it can also be others. And of course, in between, then that valve mechanism that regulates how much of excess CSF is drained, yes or no. So that is the most important part of the shunt components, the valve. because this controls how much CSF will drain. And yes, of course, we know it is now not only a valve, there are a lot of accessories that can compensate for gravity, that control the siphoning, and now we have even systems that regulate only the flow based on the secretion of CSF. Some of these systems are offered by the manufacturers as one-piece design, but usually, and I think most of you will do that, you have to put it together during the surgery. So you use connectors to connect the proximal catheter to the valve to the distal catheter, bring it under the skin. So custom made by the surgeon during and in the OR. More or less, every single shunt that we have now is based on the principle of differential pressure. So that's a pressure between the proximal end, which is in the ventricle, and the pressure at the drainage end, being in the heart or in the abdomen or pleural cavity. And neurosurgeons should at least select these valves based upon the age of a patient, size of ventricles, pressure, and maybe also on the etiology of hydrocephalus. But in most of the times, this will not be the case. And yes, we know that sometimes if you have used and selected a shunt with a differential pressure, it turns out that it either underdrain or overdrain. So you have to redo the surgery and put in either a higher or lower pressure valve. So this was standard procedures for us. To avoid that second procedures, then there was this development of adjustable valves. These were still differential pressure valves, but with a magnet from the outside, you could change the individual pressure settings, let's say from low to medium, from medium to high, and vice versa. So this could already avoid second surgeries. And also the Orbis Sigma valve, the flow regulated valves, were saying they could adjust themselves to the need and avoid overdrainage. Typically, if you look to the available shunts, they are delivered in 3 to 5 ranges: low, medium, and high pressure, and some offer very low and very high also. These are fixed. The problem is that there are no voluntary industry standards on how to measure pressure or flow characteristics of a shunt. Every manufacturer does it by himself or herself. And any kind of standards that has been described are never been adopted universally. And now it comes, there are not even industry defined values for each of these ranges. So if you have a medium pressure valve from one manufacturer and a medium pressure valve from another manufacturer, they could have completely different opening pressures. That makes it really difficult. But also that it is not a very stable thing, because due to the limitations in making these shunts and in this manufacturing process and quality control, it is not even possible to make all the shunts. If one manufacturer make 100 shunts called medium pressure, several of them will not have, they will have different opening pressure. There's a whole range. Partly that will be into the low, partly will to be into the high. So it really changes a lot. This altogether simply makes the choice of a shunt valve very complicated. And I remember when in the early 80s as a resident, I developed a self-adjusting valve. And actually that was also when I met John Holter personally, because he visited me. I discussed it with an engineer. And the engineer was looking at this and said, these are very primitive differential valve pressures, and they are not stable at all. You are not implanting these in humans, do you? He couldn't believe that we would use this really on our patients. They said they are so primitive. But it's the reality. this is what we have. So let's look still what we have 3 different types of valve mechanism. The slit valve, the famous old Holter and Puden slit valve. That's a slit in the catheter. And it will only leave drops out when the fluid pressure in the lumen of the catheter is high enough. And that depends, so the opening pressure depends on, well, the stiffness of the silicone, the thickness of the wall, of course also the length of the slit. The problem with slit valves, please remember this, is that aging of the silicone rubber and also tempering and managing that during the surgery is absolutely altering the performance of this type of valve. So it is very insecure what type of pressure management and differential pressure is really inserted here. But these are still available. Diaphragm valves are very common. It's simply by the differential pressure that we have between proximal and distal, a flexible membrane will move. So if the pressure is high enough, it will push this flexible membrane up, allowing CSF to flow through. And when the pressure is lower again, then that membrane comes back in its old position and closes off the shunt, the valve, until, of course, the pressure increases again. And then the third type is still this spring-loaded ball and cone valve. So very much actually as a Spitz and Olsen had, but they didn't have the spring-loaded ball. So that means it's a spring, could be a flat or coiled spring. And it's usually from synthetic ruby, because it's nice and soft material, that is held in a cone-shaped orifice. So when the CSF pressure is high enough, it pushes this ball against the spring. And of course, it depends on the stiffness of the spring, how high the pressure needs to be. And then if it pushes against the spring, CSF can go out. And they are still very common because they are not so much a problem with aging of the material. It's usually metal also involved. And the ball and cone and springs system has not the high tendency to clog, for example, with high protein or with still some red blood cells in the CSF. So they are still very popular valve mechanisms. Well, and then of course we have these programmable valves. That means that it is, well, we call it adjustable, I would say, is better than programmable, because they are of course not self-adjusting. The only thing is you can do that when the child or the patient comes in your office with a magnet, you can change one pressure setting to another. The moment you have changed it, it is again a fixed differential pressure valve, until you readjust it again to another value. But the moment you stop adjusting it, it is a fixed pressure. It cannot adjust itself, not at all. And therefore, in some of these cases, you need several readjustments before you really have the desired situation of your patient. It's usually with a magnet. Sometimes they can do it also magnetically, lifting something up and then mechanically turn it. But they are adjusted by a rather strong magnetic field locally. Problem is that they are susceptible by spontaneous change, for example, in an MRI scan, but also has been described that they can change by certain toys that children play with that contain magnets. So after they are exposed to a strong magnetic field, you have to check them again. These adjustable valves still have a siphoning effect. They are differential pressure valves. So they just react on the difference between proximal and distal. And if it sucks out, so if the distal is negative, then you get this siphoning effect. And therefore you either need a compensating mechanism for gravity or for anti-siphoning. And also they don't compensate well, all these differential valves, for acute changes. the daily activities, sporting, bending over, walking, being active or sporting, coughing, all these things are not well adjusted. Valves can't react on that. They just see that there is a difference between proximal and distal. And therefore, they still are prone to overdrainage. There is one type, this orbis sigma, the flow regulating valve. It keeps the CSF flowing through the valve close to the rate of CSF secretion. And that it does indeed, regardless of the patient position or anything, or other positions or coughing that usually promote overdrainage. The problem is that in the normal range of secretion and flow, they simply act not as a variable flow restrictor, but exactly like a differential valve pressure, differential pressure valve. You all know that we use some reservoirs, a borehole reservoir or an antechamber placed between the proximal catheter and the valve. You can use this for diagnostics. You can even inject also medication into the brain. You can sample CSF to see if there is an infection. So we all know that. But these are the bubbles that the patients usually feel. The problem is that we learn, maybe nowadays not so much, but if you pump it, if you push it and you push it down and it stays down, it doesn't come up, that points to a proximal dysfunction. On the other hand, if it is very difficult to push it down, maybe there is a problem in the valve or in the distal end of the catheter. Unfortunately, this is an absolutely unreliable thing to do. It is covered by the skin. It is not really reliable. Depends on the pressure. It doesn't really point out. The same is that, at least during my residency, many neurosurgeons recommended at least 20 times of pumping of the reservoir daily to keep the shunt open. This is completely wrong. You should avoid that. Never do that. The normal function of a shunt will keep it open. If you pump it, you will overdrain, and you will actually, by this pumping, suck some plexus into the proximal catheter and can cause obstruction. So these are the little problems that we have with that. Shunt problems? Some say, oh, we don't have problems. Most patients do well. Yeah, indeed, 80% of the patients do fairly well, but that has nothing to do with the fact that they are such beautiful pieces of mechanics. It only points to the fact that the human body is capable of adapting to even such a device as a shunt. And despite all the newer developments that we have, antibiotic impregnated catheters, these gravitational valves, the telemetric pressure measurements, all these, still the risk of revision and also infection is and remains the major challenge in shunt surgery. This was a study from Denmark. They had a series from 1958 to 1989, and then looked when they had the more modern shunts and shunt protocols for insertion. They saw there was, of course, the follow-up time was shorter, but there was a tendency that the overall shunt survival was a little bit longer, but only a little bit. And actually, if you look to the figures, it was not even statistically significant and also not clinically relevant. Still, overall, 4 out of 10 had a revision, and 2/3 of them fell within the first 6 months after insertion. And also the 1 and 5 year shunt survival probabilities were exactly similar. So they were very close. So this was not real progress. We know all these statistics, you can see that. Still, valve defects and proximal obstructions are the most frequent causes of revision, usually pointing to the fact that there is a kind of overdrainage. The only difference has been shown in the gravitational shunts. They show indeed a higher long-term shunt survival, so less revision, and mainly because they have less revision because of overdrainage. And that means less obstruction, no subdurals, so all of these. And the tendency, indeed, the ventricle stays a little bit larger with these shunts. But so the shunt survival is longer. That's the only difference that we can find in the literature. Now, back to the problems. We have problems with our posture of standing, sitting, laying down, being active, yes or no, but also the vasogenic problems. What we don't realize that during the night, we have periodic small increases in blood volume in the head. And you just heard the lecture by Ipachirian. I think that indeed has to do with the cleaning and the cooling of the brain. But the problem is that this nocturnal cerebral vasogenic wave activity that occurs so several times simply leads to more drainage of CSF because the shunt doesn't know that it is a vasogenic wave. They just see that because of the increased blood volume, the CSF pressure is higher. The same as when the patient strains, is active, lifting something up, or is coughing. This all pushes CSF out of the ventricles in every single valve system there is nowadays. And yes, the posture, we call it siphoning, overdrainage, and overshunting as being the same, but it's not. Siphoning is postural phenomenon because of the hydrostatic pressure when you're standing. Overdrainage and overshunting refers to the CSF that is shunted both by postural but also vasogenic effects. That's the difference. And because of this overdrainage, we see proximal shunt obstruction, headache, slit ventricle syndrome, subdurals, extradurals, secondary craniosynostosis. Many neurosurgeons say, oh, well, I occasionally see some problems with shunts. I can tell you, if you really deal more frequently with shunt, you know, and you have seen probably most of all these problems. And of course, then they develop siphon resistive devices because they react to the hydrostatic pressure. And they indeed, but they communicate with the atmospheric pressure. And therefore the problem is, if the child has a tight skin over that device, then this—
Andre, it's 30 minutes now.
Already? Oh, I thought that—
Already.
Oh, I'm very sorry. I have to quickly go there. And because I wanted to at least end in 2 minutes on how to choose a shunt. These are all the different shunts, and I have nothing to disclose on any being influenced by these. In premature babies and infants, but also in comatose patients that will remain recumbent, choose a fixed and small fixed differential pressure valve. Could be the mini NEF system or the micro valve by Kopman, or this button valve by Medtronic. That doesn't matter, but that is the best way to do. In the younger children that start to become mobile, choose a shunt that has some at least involved here, the siphon guard. The Pedigav has also a siphoning device in it, and the same here with the delta chambers. That's important. That's typically also for all patients with post-hemorrhagic and post-infectious hydrocephalus. If you see the older children and also in adults with post-hemorrhagic, think of subarachnoid hemorrhage and post-traumatic hydrocephalus, choose these, but then the larger ones, but again with this anti-siphoning device in it. There is one difference, and that is in adults with normal pressure hydrocephalus. That is an indication to choose an adjustable valve. If you follow these steps, then we can say now that we still will see some patients with problems, but at least for the last few years, we do not have problematic patients anymore. No, thank you for your attention. Sorry for taking the time. I was watching the clock not rightly.
All right,
Any
Andre.
questions? I'm happy to answer.
Thank you very much. Please answer the questions at, on the chat, because we are losing time. I now will ask Gianni Brogi to take over. Gianni,
Yes.
are you there?
I'm here. I'm here.
All right, the floor is yours.
Later on. May I make a comment to Andres? It's wonderful presentation, and very important that there is no something that is completely free of complication. And I think that the only things that we have to avoid for young people, avoid pressure from industries. That is very important.
Very important.
Thank you, Andres.
Yeah, well, welcome, Johnny.
Okay, so
Johnny, go ahead.
Yes, I will call now to the podium, virtual podium, Mahmoud Qureshi, that will talk about the management of complex hydrocephalus. Please, are you there?
I believe you can see my slides.
Yes, I do.
Thank you very much. It's been a pleasure listening to all the beautiful lectures from Ramesh, Aipe, and Andre. And listening to Andre's lecture, I was wondering whether both Casey and Dal did not actually have complex hydrocephalus, because at that time, they didn't know whether this was a simple hydrocephalus or complex, and the problems that we see with complex hydrocephalus really are what they were seeing. So your lecture was making me wonder whether that was not the case.
I think so. Post-traumatic is complicated, and also in spina bifida, the associated hydrocephalus is often very complicated.
It's very complicated. So thank you very much, Vlad and Imad, for asking me to join this wonderful team. It's always a pleasure seeing all of you. And I put everyone there on the screen because they really have become like a family to all of us, as Aipe usually says. So we'll start off with what we see in our part of the world. Really, we see a huge amount of post-infectious and post-meningomyelocele associated hydrocephalus. And really, this picture tells us the frustrations that both the children, as well as the clinicians and the mothers face with this terrible condition. So multicystic hydrocephalus is a fairly common part of our hydrocephalus seen here. And although international literature suggests, and those are possibly from Western series, that this type of hydrocephalus is about 2% of the overall hydrocephalus, we seem to see more, as I will share with you. So therefore, the definition of this is that it's also referred to as complex hydrocephalus. Some series call it multilocular, others call it multiseptate, polycystic, ventricular compartmentalization, intraventricular septations, multi-compartmentalized hydrocephalus, essentially suggesting to us that this is not a straightforward form of hydrocephalus. It's more complicated. And because we are talking about this in a neuroanatomy session, we need to recognize that in these conditions, the normal ventricular anatomy is totally disrupted. And all those lectures that we hear, and I'm sure we'll also shortly hear from Pablo, get thrown out of the window because there is no normal anatomy there. It is all abnormal and is different in each particular case. The complex hydrocephalus in this scenario is essentially multiple chambers, which are usually separated by webs. And these webs can be of variable thickness, hence the difficulty in managing these in one straightforward manner. The causation of this has really been some sort of conjecture, although there are now recent publications where groups have evaluated the development of these multicystic hydrocephalus cases and found that what Schultz and Leeds proposed as a possible pathophysiology of these septations is actually quite correct. It typically occurs following some sort of infective or hemorrhagic event, but can also follow brain trauma, surgery as well. It results in compartmentalization of the CSF spaces. And as I mentioned, Schultz and Leeds, way back in 73, proposed that this was from glial tufts. These glial tufts then protrude through erosions in the ependyma, which has been damaged. And this damage can be due to infection or hemorrhage, or even placing ventricular catheters and damaging them. So this is one of the causes that has been described. These septations then follow the organization of intraventricular exudate and debris, which then results in these compartments taking place. There are, as I said, other causes that have been recognized. Most of it is post-shunt infection, and we seem to see that more commonly in our setting because of the settings in which shunting takes place in some of our county or other regional hospitals may not be what Maurice Schuchs describes the best way of doing shunting in Marseille. But overdrainage in shunted hydrocephalus is another cause. Direct parenchymal injury, as we mentioned, when it's inflicted by a catheter tip, traumatic brain injury and intracranial surgery have all been shown to result in these multi-compartmentalized septations or multi-cystic hydrocephalus. And it does seem to be more common in children who in premature children, those of low birth weight, those that have had perinatal complications, and also those born with congenital malformation. The progression of this following the initial insult, a continuous inflammatory response to the debris is initiated or incited, and this gets perpetuated continuously, leading to a disruption of membranes arising from the interventions or shunt overdrainage, which we then try to intervene with. Other causative and continuous biological mechanisms of this complex hydrocephalus are not totally elucidated and clear, but it gives you an idea that this is a complex condition, not only in its management, but also to understand how it comes about. In our series, as I said, we had a look at this at our national hospital and found that there were many variations that we would find in these hydrocephalic patients. And as I mentioned, it's slightly higher in our settings, with up to about 10% of our, or 9% of our cases being multi-cystic. Then one looks at how do these children present and what is their outlook. Most of these children are infants with severe disability being more than the likely outlook. In these sort of scenarios, it is very unusual to see a child that will do great in school and be able to look after their activities of daily living. Psychomotor retardation is a common sequelae, despite the many advancements in management, as Andre was showing us. And there are lots of products driven largely by industry that seems to suggest that we can manage these with their products. So in truth, over 90% of these remain with severe cognitive deficits and unfortunately end up requiring assistance with activities of their daily living. So what are the management options of multi-loculated hydrocephalus? This is not a common approach, but there are many centers who will resort ultimately to an open craniotomy. I haven't done this myself, but because perhaps we now have become more and more used to doing this endoscopically, but microsurgical fenestration of the septae and its compartments through open craniotomy can be highly effective, but is more invasive, obviously, and because these are neonates and infants, it can be quite a challenge. Shunt placement, in which multiple catheters are placed in multi-loculated compartments, is essentially been the norm, but the aim of management should be to try and create a situation where one shunt system can look after the multiple compartments. And endoscopy has become the common approach to managing these conditions, utilizing fenestration within the compartments. Choroid plexus cauterization is employed in these cases. The septum pellucidum is fenestrated. And these fenestrations, when they are done, cannot just be a single opening and dilatation of the Fogarty balloon as we most commonly do. These fenestrations must preferably be multiple, enabling a large core of septal tissue to be created and excised. So you basically are making solid openings between the septae so that when they collapse, they don't close up and then refill again. So that's the approach that one needs to carry out, whether it is open or through endoscopy. And most often, a combination of these is what is required. It is exceedingly unusual to end up with no shunt. So considering the diversity and the complexity, as I said, and occurring mainly in very little neonates and infants, this can prove quite challenging. So Yun Lee looked at this and wondered what the role of craniotomy or endoscopy was. And since the suggestion of open craniotomy by Roton and Gomez in 1972, this surgical approach has increased in popularity in certain centers. A posterior parietal approach is often used, but one can go through the corpus callosum as well, with cholecystectomy closest to the loculated ventricle. And then once you're in the septum, you then open up into the ventricle. Craniotomy with fenestration allows better visualization of the compartments and membranes, offers easier excision of the membranes, and the communication can be made quite wide in these cystic compartments. Hemostasis is more easily achieved if you're doing it open. Due to the loss of CSF during surgery, open craniotomy is associated with an increased chance of hygromas and hematomas. And when you leave a shunt in that situation, the shunt malfunction is higher. And because of now the tendency to use the endoscope more and more, endoscopy has become more frequent in the management of multiloculated hydrocephalus in most centers in recent times. And fenestration tends to be performed more often as an initial treatment, and it is left for the more difficult and those patients that require repeated procedures for one to start considering craniotomy. So surgical options should therefore and are advisably done tailored to the individual case, because no one approach fits all. The combination of these is what is really required. Generally, a single shunt is not effective. And that's why Andres' talk about Casey and Dahl made me wonder whether really we'll be dealing with a complex hydrocephalus at that point. Traditionally, people have used multiple shunts placed within each CSF space as shunting each of these compartments separately. And we have had to do that in our settings. The disadvantage, obviously, includes a higher risk of shunt infection. So each shunt placement is associated with higher chance of blockage and infection. And it is recognized that hydrocephalus that is secondary to hemorrhage or infection is itself more prone to post-shunt infection. And this repeated infections can, in their turn, lead to further septations, compounding the problem. So what is the role of neuroendoscopy in multiloculated hydrocephalus? Each patient has its own, as I mentioned, unique anatomy. There is really no recognized anatomy in most of these cases. Neuroendoscopic fenestration then allows us to consolidate these multiple loculations into one interconnected loculation, which can then be resolved with a single shunt rather than a complex shunting system, which then becomes more problematic in the long term. So if one can achieve fenestrations neuroendoscopically and leave the possibility of a single shunt, this then becomes a somewhat ideal situation, reducing the risk of infection and indeed the risk of revision. This I have taken courtesy of the textbook of neuroendoscopy by Torres and Nakaji. The loculated hydrocephalus, and the picture A shows the diffuse encephalomalacia that is associated with these. There are multiple cysts and loculations due to a previous shunt infection. And this is an MRI which reveals multiple septae within it following a post-meningitic hydrocephalus. And this is, or is quite often a common picture where a skull X-ray will show a complex shunt system linking multiple catheters. And indeed, the picture on the right shows that you can get a gratifying result as a result of this approach. But what one wants to do with endoscopy and sometimes with craniotomy is to try and see if one can just get away with a single shunt. This is the MRI before endoscopic fenestration of multiloculated lateral ventricles. You see the midline shift there. A little hard to assess, but when you look at the actual size, there is a decreased ventricular size after endoscopic fenestration, and then you can then use a single shunt in this sort of scenario to achieve a satisfactory result. So without making it too complex, I think complex hydrocephalus is in itself very complex, but I put across some key messages that multiloculated hydrocephalus is an unfortunate and severe disease in which no single treatment has, in most centers, has been shown to be superior. The goal of treatment is therefore to restore communication between the various septae for implantation of as simple a shunt system as is possible, with preferably just one ventricular catheter, reducing the chance of revisions, reducing the chance of infection. The objective, unfortunately, is not to make life great again for these infants. They really are likely to end up quite unwell. But the objective primarily is to reduce the number of surgical interventions in these children. given its complexity, one must evaluate each child individually and then think through what is the best approach for each particular child. So craniotomy with web excision, choroid plexectomy, shunting procedures, and endoscopic fenestration with or without choroid plexus cauterization have all been utilized depending on a careful assessment of each individual patient. So essentially, we are sending the key message that no procedure should be ruled out, no matter how old-fashioned it may appear, because this is the ultimate aim, is to treat the child and prevent repeated procedures. In this sort of scenario, you will see lots of children with simple hydrocephalus with meningomyelocele, lots of anatomical variations in these hydrocephalic children, and some with multiple compartments. So with that, I bring you a thank you from this child with hydrocephalus. Thank you very much.
Thank you, Mahmoud. Wonderful presentation, impressing of the complexity of the pathology that you have to treat. And I think from this very severe disease, we have to learn a lot when we have, as and Andres was saying before, we have to learn how to choose this strategy for hydrocephalus. Thank you very much. There is any other comments, question from the panelists or from the audience? Andres?
Well, not only as comment. We have been together in other webinars on this topic on complex hydrocephalus, and the interesting thing is that some people say every case of hydrocephalus is complex because the disease in itself is complex because we don't understand it so well. But this is multi-compartmental disease, so post-infectious, and the big trouble that we face is the fact that the moment we see these patients coming in and we already have to develop a strategy, that disease, that inflammatory reaction of the ependyma, has not even ended. So you open 1 and 2 compartments, and then after 6 weeks, there are 4 more compartments that you need to open. So it's an ongoing disease. From very early on, if we see something like that, we tell the parents, we'll have to travel a long roads together. And you have to realize that we have to operate on your child multiple times. So, because otherwise they are frustrated, said, what went wrong in the first surgery when you have to do it again now? And so very early on, make it clear that this is not a simple case. I actually also say it with shunts. If you place it in an infant, in a newborn, the chances that you have to do a revision in the first year is so high that I already tell the parents from very early on that this is the case and that nothing has to do with some kind of medical error or we did something wrong in the first time. It is the disease. And also that we say, listen, but we do this together, we are there. And I tell my residents, you can't step away from these. You have to be there, you have to be there. They usually come back in with a problem on Friday evening or Friday night. They never show up on Tuesday morning at 11 o'clock.
Right.
That's the problem. Because they say, oh, we don't dare to go the weekend into this with the problem because he's vomiting again since two days. We all know these patients, when you get this call from your from the hospital and they say the name, you already say, oh no, not again.
Not again.
I had these that you know the name. I still now remember those names that I say, oh, if hopefully it is not that case again. But if we do this is complex hydrocephalus. You beautifully showed that, Moody.
Thank you. Any other comments or question? If not, I will ask to Pablo to go ahead and give us the lecture about ventriculostomy. Please.
Here I am. Just let me know if you can see, Giovanni, the screen.
Okay.
水頭症に関して、
Yes, we can. Yes, we can.
水頭症に関してですね。
Okay.
ありがとうございます。
So it's always challenging to speak after Moody, but I'm so lucky. So
次に行こうと思います。パブロ・ゴンザレス・ロペスですね。それで、次のものも読みましょう。
yourself.
パブロ、よろしくお願いします。
Sorry.
いつもありがとうございます。それで、
Let me try to do it myself.
Yeah, you have.
Okay.
It's okay.
Did it. Sorry. So thank you, Moody, again for your sharing your experience with us. And I'm so lucky not only because of listening to you, but also because I have been very lucky to be behind you when you were doing these complex cases in Zanzibar and in Kenya in your place. So thank you again. But I do believe that before understanding this complex anatomy, it's basic to understand some normal anatomy. And my goal is to explain simple tricks to find which is your target where you are inside the ventricle in order to perform a successful third ventriculostomy, endoscopic third ventriculostomy. So I will go fast through the history, but I do believe that we have to do a deserved tribute to those who laid the groundwork for modern neuroendoscopy development. And in this sense, I highly recommend you this paper from our colleague, Professor Henry Schroeder in World Neurosurgery, in which you can find the most interesting findings in this sense in the last 1.5 century. So the summary of this brief talk will be trying to understand the anatomy inside the ventricles in an endoscopic way and also in a microscopic way, and to describe step by step how we do our surgical planning and surgical procedure, and how these two things together can help us to avoid complications. So first thing is that when we are thinking about approaching the ventricles with a small camera, with a very thin camera, which is our endoscope, we have to understand the cortical surface, because this is what we are gonna be crossing with the endoscope and with our cannula. So we have to choose perfectly our ideal cortical gray matter entry point. Another thing very important is to understand what we are crossing, what we are traversing or running parallel to with our endoscope, which are the white matter fiber tracts. And in this sense, we must choose a trajectory which is most likely parallel to the most important fiber tracts. And finally, we have to choose our target in the floor of the anterior third of the third ventricle. And in this sense, we should consider the septum pellucidum, fornix, thalamus striate vein, and other structures that we will be highlighting during the next slides. But once we are inside the ventricle, sometimes, as Moody has highlighted, it's very, very difficult to orient yourselves. But in most of the cases, we will always have something familiar. And the 6 most important structures are the septum pellucidum, which is exactly in the midline. So this can be helpful to orient ourselves to know in which lateral ventricle we are. The caudate nucleus, we have the head of the caudate in the frontal horn, and the body, all around the body of the lateral ventricle. Another important structure, very important, is the fornix, not only because it runs parallel to the septum pellucidum in the midline, but also because in the foramen of Monro, we have a kind of curve in the anterior and medial wall of the foramen of Monro. So we must try to avoid damaging this structure. In the roof, we will be crossing the corpus callosum. So this is the last entry to the ventricular system. We have to consider the white matter fiber tracts, which are lateral at the level of the ventricles and through which we are running parallel. So this is the corona radiata, and finally the internal capsule. And finally, in the floor, we will discover the thalamus in the posterior part of the lateral ventricle. So let's go to try to identify these structures in this step-by-step endoscopic third ventriculostomy. And the step 0 is anatomy and indications for ETV. And it's obvious that most of the cases in which we will be indicating an endoscopic third ventriculostomy are those ones in which we have an obstruction of the CSF. And what we want to do is just reestablish the circulation from inside the third ventricle to the cisterns, to the basal cisterns. So this is the goal of the third ventriculostomy. Step 1 is to try to identify some of these success anatomical predictors, and in this sagittal cut, we can identify some of them. So we have a bulging tuber cinereum in the floor of the anterior third of the third ventricle. We can have a bulging lamina terminalis. And we have to try to identify if we have enough space in the prepontine cistern, because this is where the flow of the CSF will be going to. We have to try to identify the capricious anatomy of the basilar artery, because this can reinforce or modify the target in our third ventriculostomy, and also a very thin corpus callosum. So once we have identified all these structures, we are gonna go to the next step, with is surgical planning. So surgical planning, generally, we do a start setting the target. And the target will be generally in the anterior floor of the third ventricle. And it's very important, as we have just mentioned, to try to identify the basilar tip. Sometimes it's located in between the mammillary bodies, but sometimes it can be more anterior. So we must identify this in our preoperative MRI when possible. And then we will trace our surgical trajectory. How we do that? So the most important thing is not only to reach our target, but to leave all the structures completely intact in our way to the anterior third of the fourth ventricle. So for that, we will have to try to respect the fornix, which is located here, as we have been highlighting, in the medial aspect and anterior aspect of the foramen of Monro in the right side, as we can see here, the thalamus striate and the septal vein junction, and the hypothalamus, which is located in the lateral wall of the third ventricle, just parallel to our trajectory with the endoscope. Finally, we will try to identify what is the basilar tip, and we will try to penetrate the tuber cinereum in a safe location. So this is how we do this. We first of all trace our target, which is located just anterior to the basilar tip, as we can see here. Then we place the second point exactly in the center of the foramen of Monro. And finally, the cortical entry point will be given by this trajectory. So we join these 2 points, and the cortical entry point will come up later on. So these are all these structures that we have to take care of. So let me show you how we do it with this software. In case we don't have navigation, we can do it easily. So first of all, we go to our target, which is the anterior aspect of the floor of the third ventricle. Then we place the trajectory in the center, exactly in the center of the foramen of Monro. And finally, this is how we can customize our entry point, just a couple of centimeters or 3 centimeters lateral to the midline. So this is how we do it. We take all the measurements, and then we go to our surgical planning. So in this case, we went almost 13 centimeters posterior and 2.5 centimeters lateral to the midline. So how we can do that? We can use the navigation, which will give us a much more accurate and precise cortical entry point and trajectory. And in case we don't have it, or we are in the emergency room at night, we can do it with just a simple rubber like this. So this is the fast neuronavigation kit. This is Dr. Patrick Barchi. He's one of our ex-residents, and we have checked that it's working quite nicely if you do it carefully in all your cases. This is a nice paper in which the authors were analyzing the most common entry point for a third ventriculostomy. And it's curious that it was located a little bit posterior to bregma, as you can see here. So 1.2 centimeters in average posterior to the coronal suture and to the bregma, and almost 3 centimeters lateral to the midline. So that was the most ideal cortical entry point. Step 3 is positioning and the OR setup. So it's very important that the surgeon's view is perfectly free, just in front of him. So he must have the patient in between himself and the monitoring, which we will be looking at. This is Zanzibar. This is myself making a big mistake, because we place the nurse assistant just in between ourselves. So this is not something recommended. But look at Professor Qureshi, he's doing it perfectly. He's just in front of the screen, and his assistants are in the left side. So nobody is obscuring his view to the monitor. This is something very important that can annoy our procedure in case we place something. So this is how we generally do it. Another important thing is checklisting your instruments. Make sure before opening the skin that everything is working properly. Your light, your source light, your camera, your instruments are passing through the working channel properly, and then you can go to the surgery. About the skin incision, we can do different skin incisions, and it will depend on the procedure itself. In case we are gonna practice a single bar hole, we can use a linear incision, which is the one I like most, or you can use the C-shaped incision. But sometimes we need to do a biopsy in the posterior aspect of the third ventricle. So in these cases, we prefer to do this extended curvilinear incision so as to have 2 bar holes, the anterior and the posterior one. And you can combine each of them in case you want a mini craniotomy in order to feel more comfortable, and with the same trajectory, with the same entry through the cortical surface, you can do the biopsy and the ETB with one entry point. Ventricle cannulation is the first step after opening the dura and coagulating the cortical surface. So this trajectory, as we have said, will be running in between our target, the foramen of Monro, and our cortical entry point. So ideally, it will be running parallel to the anterior limb of internal capsule corona radiata projection. So we will be running parallel to these fibers in our way to the frontal horn and finally to the floor of the third ventricle. So before cannulating, what we are doing is coagulating the cortex. This is a surgery we did yesterday with Carlos Martorell. He's the one who is cannulating the ventricle. So we use this cannula, and once we have checked our measurements, we go with the endoscope and we realize that we are somewhere inside the ventricles. But let me take your attention to this fact. If we are using this cannula, and this is something that I learned from my mentors, what we are watching is what is coming directly from the camera, but we are not watching what is happening in these 2 millimeters of the camera. So let me show you what I mean. If we are inside the cannula, we can see everything, but once we are outside the cannula, we are missing part of this area. And this is something very relevant, as I will try to prove you with this slit ventricle syndrome patient. So this yellow area, we are not able to watch it. So let me show you what happened in this case. We were entering without any cannula directly through the foramen of Monro with the endoscope. We are watching the mammillary bodies here. So we did a successful third ventriculostomy, but look at what happened. We completely damaged the fornix. So we fixed the problem of the patient, but we created a new problem damaging this fornix. So this is very important. And unfortunately, we are learning sometimes from our mistakes. So let me explain you with this cadaveric specimen what I exactly mean. I'm entering here with the cannula. This is the foramen of Monro, very, very small foramen of Monro. Now I'm introducing the scope. I go backwards in order to make sure that the cannula is completely entering through the foramen of Monro without damaging the fornix. So now once I am inside the third ventricle, I introduce the camera. And with this maneuver, I will make sure that I am not damaging the choroid plexus or the fornix, as you can see here. So the fornix is intact. But let me show you what happens if we enter directly with the endoscope. Choroid plexus, we go quite posterior, pushing the choroid plexus, but look at what's happening here. We are not aware of this 2 millimeters part, and we have damaged the fornix. So a good advice is go with the cannula, cross the foramen of Monro with your cannula, make sure that you are not damaging the structures, and once you are in the third ventricle, go inside with the camera. So this is an example of what is happening. We don't have a mirror in our endoscope, but you must be aware of what's happening behind you. We have the mirror in the car, but sometimes we fix our target and we don't take care, we don't pay attention to what is happening behind, and you can cause a terrible damage to someone. So please make sure that you are not damaging what is happening behind. So this is the case in which this is the yesterday's case indeed. So we are entering with the cannula. This foramen of Monro was big enough, but look at the wide view we are having. So once we are in the third ventricle, we introduce our scope to this region. So another important step is anatomical identification. And as we have been highlighting, we have very important structures: septal vein, thalamostriate vein, mammillary bodies, choroid plexus, and the tuber cinereum. But sometimes once we enter the ventricular system, we can have a crazy view like this. And we have a vein here, some choroid plexus, this could be the thalamus, I don't know if this is the fornix. So before any attempt, try to orient yourself, moving the camera. This was a chronic hydrocephalus. So this is why the septum was completely opened. So we were in the right ventricle looking at the left ventricle. But once you identify the choroid plexus, just follow it anteriorly, and it will always end up at the level of the foramen of Monro, in between the septal vein and the thalamus-striate vein. So even in the most difficult anatomical scenarios, try to find these fixed structures. What happens once we reach the floor of the third ventricle? There are many, many papers talking about which is the ideal entry point to the to create our stoma, and generally it's located in a rhomboid structure in between the infundibular recess, mid aspect of the mammillary bodies. We trace this rhomboidal shape, and then we try to penetrate, most likely in the center of the rhomboidal shape, but always depending on the location of the basilar tip. So this is how we are enlarging the stoma, and sometimes we must be aware of is the capricious anatomy of liquid membrane. Sometimes the liquid membrane is not there, so we enter directly from the floor of the third ventricle to the prepontine cistern. Sometimes, by chance, we penetrate it directly. This happens when the diencephalic layer is just attached to the floor of the third ventricle. So here we have the diencephalic and the mesencephalic penetrated. This is the prepontine cistern. And sometimes we can have a very, very low mesencephalic membrane. And in these cases, it's very important to try to penetrate it also and communicate the interpeduncular cistern with the prepontine cistern. So take your time to make sure that you have opened all these arachnoid layers and your stoma is communicating the third ventricle with the basal cisterns. Checking pulsations is something that it's quite nice. Once we have done our stoma, due to the pulsations of the brain and the CSF, we can check that the stoma is open. We can also check it in our post-op MRIs, in which we see this flow signal going from the third ventricle to the prepontine cistern. It means that the ventriculostomy is working properly. And sometimes, like in our case yesterday, once you do the perforation due to the high pressure, your floor of the third ventricle will be closed. So once we open it, look at what can happen. This tuber cinereum, which was really, really enlarged due to the pressure, it starts being closed because the patient is losing pressure. So in these cases, we increase the irrigation in order to see where to work and to see the basilar. So once we increase the irrigation, we are opening again this tuber cinereum, and we make sure that the basilar is not being damaged with our maneuvers. So step 12, hemostasis. Hemostasis is mainly carried out with continuous direct irrigation. In cases we cannot control the hemorrhagic vessels, we can use balloon compression. And for closure, this is our thinking. Obviously, we are dealing with a higher pressure than in the extracranial pathway. So this is why we like to place some spongostan layers and some bone wax in order to keep this higher pressure, to keep the stoma opened. Do we place an EVD after the endoscopic third ventriculostomy? Not in all cases. In most of the cases, we don't do that. Depending on the clinical presentation, in cases of acute hydrocephalus and the patients in comatose state, we consider to do that in order to check the intracranial pressure. But in those ones in which we have subacute or chronic hydrocephalus, we do not place an EVD. And key factors to consider, just to finish the presentation in endoscopic training, are understanding this intraventricular anatomy, acquiring surgical skills, and performing the surgical planning. And in this point, surgical skills, the truth is that we are not really made to this endoscopic work. So this is why we created this very, very simple toy with some of the cooperation of the university and our hospital and Net Foundation. And I must say again, thank you to Moody, because he was part of this project when we tried it a couple of years ago in Zanzibar. So we created this very rudimentary endoscopic training system, and we performed a couple of courses with Professor Qureshi in Zanzibar and with Professor Jose Piquer, who is the president of this foundation. And we were able to discuss some important points and to check the usefulness of this toy. So we were doing some ventriculostomies, and let me show you the first preliminary results. So this is the choroid plexus, this is the foramen of Monroe, this is the tuber cinerum. This is one of the trainees, the first time he was doing the exercise. So he was penetrating tuber cinerum, he was trying to insert the balloon. So he was experiencing the difficulties of dealing with the endoscope and the working channels. And I will not show you the whole video, but the thing is that we missed all the time, almost 6 minutes, 2 fenestration repetitions, 23 stoma attempts, 4 hypothalamic contacts, 6 fornix contacts. And only after practicing 6 times this procedure, he was able to do it much nicely. Only in 2 minutes, single fenestration, very fast stoma, he was able to open it nicely in one shot. Zero hypothalamic contacts on only 1 fornix contact. So as you can see, it was a quite successful experiment. And just to summarize, I really recommend to study each case individually with a careful study of indication and success imaging factors, as we have been highlighting. Track the trajectory based on individual anatomy. This is very important, always from distal to proximal. Plan the incision and bone work based on the procedure itself and possible second procedures. Try to identify your anatomy and remember what is behind your eyes. This is something very important when we are working with the endoscope. Try to perform and enlarge the stoma in the safest possible area and check always that you have opened and communicated the cisterns. Try to perform a watertight closure so as to keep enough intraventricular pressure to force the stoma open, and always don't follow dogmas and apply each step of surgery for each individual case. Let me thank all my colleagues in the department here in Alicante, and especially the best group of residents, Cristina, Enrique, Carlos, and Artem, that are like a dream to work with them. Thank you so much.
Thank you, Pablo. Wonderful presentation, and with a lot of suggestion for young people and for not so young people to perform this excellent approach for hydrocephalus. There is any comments, questions from the panelists?
Yes.
Yes,
thank
please.
you, Pablo. This is a very useful lecture, as always. To prevent some damage to brain structures, videos are excellent. In the case you showed us of injury to the fornix, the patient had some change in memory.
Well, thank you, Victor, for your comment. The truth is that we did not perform a deep neuropsychological assessment because we don't have psychologists in our health system, so we cannot do that. But in general terms, he was doing quite well. For the 3-4 days he was in the hospital, but it's not my case. I cannot tell you a long-term follow-up, but I have the feeling that he was doing quite well.
Thank you. Excellent.
Any other question? If not, I have one nasty question. All of us are almost always go to the right side because the majority of the European are right-handed. What about the left-handed? And second question, is any advantage of doing DTI as you show in the first slide?
Well, about the first question, generally we use the right side because it's not only because of the reason that you mentioned, which is key, but also because it's more comfortable for a right-handed surgeon to hold the endoscope and for a right-handed assistant to perform the stoma. But for instance, this morning, by chance, yesterday night, we had a patient coming to the hospital, and we have performed this morning a third ventriculostomy, and the patient had a shunt in the right side, so we close it, and we perform the third ventriculostomy through the left side. So I mean, again, as I highlighted in the last slide, following dogma, sometimes it's making our life more difficult. So I generally don't do that, but yes, by definition, I use the right side, and maybe this is something that is in our mind. And about the second question, I don't usually perform DTI tractography. I just wanted to show you how we are running parallel to the corona radiata, but we don't do tractography in most of these cases.
My question was because the real danger of this procedure is the pivot that the endoscope has on the foramen moroid, so the damage of the this structure. First, in the left-handed, maybe the structure more important on the left side, and vice versa. So I mean, you know, technology. I don't think that DTI is so useful. It's just making the surgeon less anxious. That's my opinion. But nevertheless, we have this technology. So, okay, thank you so much for your presentation. There is any other question or comment? If not, Vladimir or Imad, will go you ahead presenting the next one, or should I do it?
As you wish, Johnny.
Do it. My friend Henry Schroeder, endoscopic CSF pathway, reconstruction in not in exclusive hydrocephalus. I think that is very important to hear. Please, Henry, are you here?
Yes, he is.
Wow, that is something.
My lecture is gone, so I have to open it again. One moment. You see already the screen, right?
Please go ahead, because we are this time not running out of time, so we have time for question and.
That's good. Do you see it?
Yes.
So first, I want to thank Imad again for inviting me, and Vlad. It's a great pleasure to be here. And my topic is endoscopic restoration of CSF pathway obstruction, and I want to show you some techniques what we do additionally to ETV. So at first, the endoscopes, what we use are the lotoscopes. We have two different sizes depending on the size of the ventricles and depending on the procedure what we want to do. And for most of the ETVs, we use a small one because we want to go with the endoscope through the floor of the third ventricle into the basal cistern if there are arachnoid membranes which should be fenestrated. If we have a subdorstomy and we have wide surgical cavities, we take the standard lotter because we have more effective instruments like scissors or bipolar and so on. And this is our setup. As Pablo mentioned, we should sit in a very convenient way that we have a straight view to our monitors. So we have the endoscopic image here and we have navigation or MR imaging on the other side. And what is the aim of endoscopy in hydrocephalus? Of course, is the restoration of CSF circulation. Sometimes we remove the causing pathology, for example, colloid cyst or small intraventricular tumors. But most of the time we want to restore the CSF circulation. But sometimes, you know, sometimes it's not only an obstruction, but it's also an absorption problem. And then the endoscopic technique alone is not enough, and we have to combine it with a shunting procedure. What is very important is that we do a good MR imaging before, because we have to individually plan our procedure and especially the trajectory. If you have a microsurgical operation, you make a craniotomy, you can look from the left side and from the right side, from up and down. But if you have endoscopy, you have just one borehole. And if this is not placed correctly, then you have a problem to gain access to your target area. So aside from T1 and T2 weighted images, we have this inversion recovery turbospin echo sequence, which is a flow sensitive sequence. And you should see a black signal going through the aqueduct. If this is missing, it shows that there is an obstruction. Additionally, we have this high resolution T2 weighted imaging. We use a CIS sequence, what means constructive interference in steady state. I think sometimes is also called drive or Fiesta, depending on the machine, what you have, but with the Siemens, we call it CIS. And you see, because of the high resolution, you see exactly all structures, the bulging of the floor, the distortion of pituitary stalk, the pre-stenotic dilation of the aqueduct, and this is all very important. And also you can see membranes in front of the brain stem, which is also a very important finding before you do the surgery. And then, of course, you can see after the surgery, is there a success? You see here, for example, this is pre-op, this is post-op. You see again, the stalk is visible, the prestenotic dilation is reduced, and in the Urze, in this flow-sensitive sequence, you see the nice flow void through the floor, showing you that you have achieved a good ventriculostomy. So approach planning is very important. For example, here you see this is a young girl with headache and vomiting, and you see a dilation of the third ventricle, bulging of the floor, and there is a tumor in the aqueduct. So what is the aim? Of course, you want to release the CSF pressure, so an ETV should be done. And also we want to take a biopsy because we want to know what kind of lesion is it. Can that be done from one borehole is a question. And many people say, yes, we place the borehole not at the coronal suture, but 2 centimeters in front, and then we can reach both targets. What I frequently see is that people do not look at the bottleneck of the approach. And the bottleneck of the approach is the foramen of Monro. And if you look at this patient, you see the foramen is extremely small. So in this case, if you want to go from the same borehole to the floor and to the aqueduct, you will destroy the fornix or the veins and you have hemorrhage. So this cannot be done. So what is the solution? We can make a straight trajectory to the ETV and take a flexible scope for the biopsy, or we take a straight approach for the biopsy and take a flexible for the ETV. And if you do not have it, you need 2 boreholes, one for ETV and one for the biopsy. So it's very important. So I have seen as an expert witness in some lawsuits really disasters occurring because people did not look at the anatomy of the case. The foramen of Monro can be very large. You see there's a floor, there's the aqueduct. It's no problem to go to both areas via one borehole, but if you have a small foramen, you should not do that. That's a main message. Head positioning is always important, and we try to place the head that the borehole or the opening of the skull is at the highest point to avoid abundant egress of CSF. Sometimes if you place the patient in a less than ideal position, you see airs coming in and then you get a mirroring on the surface because sometimes you have air in front of the lens, sometimes you have water. That's not good. So I prefer an endoscope holder. So I don't like to have the endoscope in my hands and the assistant is doing the ETV or the other way around. I always find it safer that I have an holding arm, and there are multiple arms on the market. I prefer the pneumatic one from Mitaka. It's very reliable and you can easily adjust it, and you just press a golden button here and then you bring it in and it's fixed. And navigation can also be added if you have an approach which is not familiar with you in cystic lesions or ependymal cysts or for septostomies, then always it's helpful to have navigation. If I don't have a navigation, I use, before I insert a 6mm endoscope, I take a Scott cannula to puncture the cavity. And if you hit it, it's fine. If you don't hit it, of course, I try to correct it with a small catheter and not with the endoscope itself. So occlusive hydrocephalus, what techniques do we have to treat it? We have septostomy, foraminoplasty, ventriculostomy, aqueductoplasty, and stenting. And I just want to explain when we use which one. So septostomy is always indicated if one foramen of Monro is occluded and the other one is patent. Then it's much easier to make a septostomy than to make a foraminoplasty. If one foramen is closed and you make a foraminoplasty, I would not understand because there is a fornix and there's a much higher risk to get damage than to make in septostomy. Septostomy is usually very simple. The trajectory is more lateral. It goes 5 or 4 centimeters, sometimes even 6. Sometimes you want to make an ETV and septostomy, or you want to take a biopsy in a septostomy, then of course you had to adjust. But if you want to make purely an septostomy, you come from the lateral side so that you have a perpendicular view to the septum. This one case, he underwent resection of thalamic glioma, and after surgery, he had a problem here with the CSF circulation in the trigone. So we have a dilation of the temporal horn and of the occipital horn and part of the sella media. So what we do in this case, we go in from here and we want to make a septostomy on this side. If you go in, you know there are no landmarks. Maybe we see the internal septal veins. That's why you use navigation for the planning. You see the internal cerebral veins. These are the only structures which may guide you. So we take in navigation to plan the approach from the surface to the septum. And then we insert the endoscope under navigational guidance. And you see we look to the internal cerebral veins. And here there must be the ideal point for the fenestration. Then we have a trick. We use the jet irrigation technique. And then you see flotation of the thinnest part of the brain. And you can identify where is the best place to make a fenestration. So not only navigation, but also this forced irrigation. You make sure here must be a very thin septum. Then we use, we look for a avascular part of the septum, we coagulate. And then we take a small 1.2 millimeter scope to check whether we really reach the ventricle. And you see it's okay. We see the contralateral ventricle and the coral plexus. So sometimes if you open here the one layer of the septum, you may end up in an interseptal space. So that's why it's always important that you open really precisely everything and look to the contralateral ventricle, and you can identify it most easily if you see the coral plexus of the contralateral side. So the technique what we use is we make a circular coagulation. We do not want simply to dilate, not like in ETV, we make a penetration and we dilate a balloon. No, we want to resect a little bit. And ideally, the size of this resection should be at least in diameter 6, better 10 millimeters, depending on the size of the septum. Then we cut all these residual bridges without the last one. Please don't cut the last one, then the flap flows away and it's hard to find it again. So the last one is taken with a biopsy forceps, and then the whole flap is removed. And then we have a coagulation. And you see it's a large opening and the reclosure rate is very, very low. We had just a case where we had an infection, an active ongoing infection. And there we had a reclosure by fibrin membranes. And we look to the contralateral side, you see the plexus here. And this is the ideal way to make a septostomy. And usually success rate is very good. You see rapid resolution of the size and also improvement of his problems. So very safe technique, high patency rate, it's really recommended. So foraminoplasty. Foraminoplasty is done if both foramina are occluded. So we have a bilateral hydrocephalus. That is a rare, but it can happen. And then we just open one. If the septum is open, just one foraminoplasty is enough. If this would be closed, then I would do a septostomy and a foraminoplasty. I would not go from the other side and make 2 foraminoplasties, because then you have 2 fornices at risk. And this should not be done. You see it's one patient with a dilation of both lateral ventricles, and you see foramen of Monro seems to be occluded. Then we go in, you see the septum is open, so just one foraminoplasty is enough. And you see there is hard to see, you just follow the coral plexus and this guides you to the foramen. Then you see the big veins around the foramen. So the first step is we coagulate the coral plexus. And then we take Fogarty balloon catheter and we dilate. Very careful, you must imagine this is all fornix. You cannot make it really large, otherwise you get the damage. Then we go in with an endoscope carefully and we look to the third ventricle. So communication is established. And then because the foramen is so small, I'm afraid it will close again. And then I take a stent. I just take a ventricular catheter, have perforations on a side, and we put it into the third ventricle, just that we do not a recurrence, because the foramen was restored, but it was not very wide. So then you remove the ventriculoscope and the sheath, and then we take a small endoscope going along the ventricular catheter to check whether it's still in or it's dislocated. So we can go in and we look down and we see, yes, the catheter is still in place in the foramen. That's okay. And you see the post-op MRI shows decreased size of the lateral ventricles, and here is a stent in place, which is connected to a Bohr reservoir and fixed here, so we get not a stent dislocation. Here you also see the placement of a stent in the third ventricle. So foraminoplasty is a nice technique, but you must be careful because it is fornix, which is sometimes very close to the foramen. It's not just, sometimes you have, or we had one case where there was a thin membrane in the foramen. That was easy. But usually the whole foramen is very narrow and the fornix is very close to it. Another technique which is also useful, although it's also very rare, it's a temporal ventriculostomy. This can happen if you have an isolation of the temporal horn and you have a very thin temporomesial ventricular wall. Then it can be done. This one case, this was also after tumor surgery. There was an occlusion here in the dorsal part of the temporal horn, and you see the massive dilation of the temporal horn, and you see it's a very thin membrane. It's not thick, it's very thin, and you see there is some space to the suprasellar cistern. So only if you see these ideal conditions, then I would recommend to do it. Otherwise, I would not do it. You must be careful when you open up because there might be some vessels in front. So navigation is of course used for that. We go in, you see here, this is the hippocampus. And here's the thinnest wall exactly over the head of the hippocampus. And we take the deck forceps and we open one layer. Then we go more down, we open the second layer. So we do not just puncture it because we do not what is in front. Must be very careful because there are some vessels. So we open it again. Then we take the Fogarty balloon catheter to dilate it. And the balloon catheter is filled with saline to avoid this pop-optic phenomenon. So we have a constant, slowly enlargement of the balloon. Then we take a bipolar and we resect a little bit of this brain tissue to achieve a really large opening. Careful deflation. And then we can take a 30-degree endoscope and look in, and you see here, this is a pituitary stalk. You see the arachnoid around, then we turn it down, and you see here P1 oculomotor nerve, superior cerebellar, and we can even look down to the prepontine cistern. So a very good communication has been achieved. And then the endoscope is removed. And we have done so far 5 cases, and all have been patent, so we did not observe occlusion. And you see a little bit flow void here. Very rare, but ideal. Here, ventriculostomy, Pablo has already talked a lot of it and nicely. So what I do not do is that I go behind the coronal suture. And I also do not go too far laterally. And the reason is if you go too far laterally, you have this tangential access to the floor. But I want to perforate the floor ideally exactly in the midline. Otherwise, I go to the right side, I go to the, maybe I go to the oculomotor nerve or I go to the PCOM. So I want to go more straight. And the foramen of Monro is not a rigid structure, but it can a little bit, it can be moved with the endoscope tip. So that's why usually I go 2.5 centimeters and just in front of the coronal suture. So this is our routine entry point, and so far it's really sufficient to get there. Of course, if you take navigation, you make examinations, it's correct. Sometimes you will end up a little bit more posteriorly, but it was in a clinical case, it was not a problem that I say I could not reach it or I did the damage to the fornix because my borehole was at the wrong position. And usually I do it freehand and not with navigation, but we can discuss whether this is a good idea or not. And then again, we take a Scott cannula to make a fenestration, to make a puncture, and I check the trajectory, is it okay or not? This is usually the floor, what you see, mammillary bodies and fundibular recess, and then of course, we want to place it here. And the ideal point in my experience is usually in the midline, just behind the clivus. If you go too far here, too close to the infundibulum, it's not good. Although endocrinological problems might be rare, I would not do it. But the worst thing is you go through the thinnest part, which is frequently in between the mammillary bodies, because then you end up behind the perforators. And if you then dilate the balloon, it may happen that you rupture one of the perforators. And we had one lethal complication because of a rupture of a perforator, because the surgeon placed the Fogarty catheter behind the basilar, not in front. This should not happen because this is really a mistake. Balloon catheter for dilation, and then you see there is a liquid membrane below the floor, and this has to be open. It's very important. And sometimes you have even more membranes deep down. I always want to see after my ETV the view to the basilar artery to make sure I have opened sufficiently. It's one example. You see here's a young girl, and she has an tactile glioma as a reason for aqueductal stenosis, and you see the bulging of the floor. This is an ideal case for ETV. So we go in, and you see the foramen of Monroe. Here we have a wide foramen, so I can go directly into the third ventricle. You see mammillary bodies. It's a translucent floor. This is the ideal case what you want to have. We never use the Fogarty balloon catheter for perforation because the catheter is flexible. It might slip to one side or the other. I always take the deck forceps because a rigid instrument, and I make my fenestration where I want to do it. And then the Fogarty catheter comes as a second part to dilate this perforation. And you see that if the floor is moving up and down and is thin, you have to play with the balloon catheter to find the best place and to make an opening. And you see here is the liquid membrane. And again, this membrane has to be opened additionally. And if the arachnoid is thin, Fogarty balloon catheter is fine. Sometimes it's more firm, and then you need scissors. You see the flotation is a very good prognostic factors, but still we use a 30-degree endoscope looking to the basilar to make sure we end up in the subarachnoid space. If you go too far anteriorly, and we had also one case, you can end up in a subdural space. And then it's the wrong space because you have no communication. And you see if the borehole is at the correct position, you have no damage to the fornix, and everything looks fine. Post-op MRI, what I said, an inversion recovery turbоспine echo shows nicely the flow void. And then also you can see that the bulging is gone from pituitary stalk as a sign of the lesion. So we have done in Greifswald 462 ventriculostomies in the last 20 years. Success rate is depending on the etiology very good. Best in tactile gliomas, a little bit less in aqueductal stenosis. We had 2 cases where there was a mortality. One was an old guy who got an infection because he had the ventricular catheter before. And one is what I told you was a rupture of the perforator from the basilar tip. But it's a very safe technique if some precautions are taken. In children, the success rate is less. You see below the age of 6 months, we have a high rate of shunt dependence. This, I think, is not a good indication then for ETV. There are sometimes extraventricular CSF pathway obstructions. You see the aqueduct has a good flow void. You see a little bit bulging, so there must be a pressure differential between the third ventricle and the subarachnoid space in the prepontine area, and you see some membranes here between the clivus and the brainstem. And we think this is also an indication for an endoscopic subventriculostomy. So again, we go in to the third ventricle. This is all done with a little otoscope. So we open the deck forceps, and we take again the Fogarty balloon catheter, which is pre-filled with saline, to have a constant enlargement while inflating the balloon. So we open it. The double balloon catheter is also an option, but it's too expensive. That's why we still stick with a standard Fogarty, which is very cheap. And you see there is another membrane. It's not the Lilliquist. Lilliquist is up here. There's another membrane deeper down. So we go in with the sheath of the lotoscope, which is 4.5 millimeters. And then with scissors, we have to cut this. It's very firm. It cannot be opened blindly. And with my sheath, I protect the basilar, which is here on this side. And if we have cut and perforated this, we take a Fogarty balloon and open it. And you see down here is the abducens nerve. We open all these arachnoid. And then you think only after we open this, it starts to pulsate. If you don't make this opening, you do not see the pulsation, and then your ETV probably will fail. It can also be done ETV in retroventricular hydrocephalus. It's just easy. You make simply an ETV, although there's almost no space, you can do it. It's very effective also in this. Even in shunt failure, this was a lady, she was 40 years shunt dependent. She was a visitor in the summer months here in the Baltic Sea, and she came with acute hydrocephalus with vomiting, nausea, and we see this dilation of the ventricles. The shunt is in place, but you see the reason is an aqueductal stenosis, and you see the bulging of the floor. So we make a third ventriculostomy, and immediately she was free of symptoms, even after 40 years of shunt dependence. And all of our cases, what we evaluated some years ago, we had a success rate of 60% in shunt failure. Success rate in communicating hydrocephalus is very low, so we do not recommend it. But if we see an obstruction, then we would recommend to make an ETV and try to avoid the shunt. Aqueductoplasty is a technique which also seems to be very reasonable because we restore the physiological CSF flow. So ETV is a side hole, but to restore the aqueduct in aqueductal stenosis seems to be very nice. And the procedure is really nice. You go in. You see here, we have what Pablo mentioned. We look at the shaft and at the edge of the sheath while introducing it if the sheath is large in relation to the foramen of Monroe to avoid this damage what he has shown. It's very important that you go with the endoscope into the sheath so you see the margin of the sheath. Only if the ventricle, the foramen of Monroe is very large and you have a small endoscope, then it's not required. So here we used a flexible scope because it was a distal occlusion. This is not the clinically relevant stenosis. It's also a membrane, but this is not the main problem. The main problem is further down at the entrance into the fourth ventricle. And you see here is the small pinhole, which is still open. And then we take the scope for perforating the balloon and we are within the fourth ventricle. And then we go down and you see here foramen of Marjan-D. It's open. So this is a technique what we used frequently in the years, and we were very happy with it. But then we make an evaluation of the long-term outcome, and we published it last year. And we had 20 patients. We found 17 for follow-up, and 11 patients had a clinical relevant stenosis, need an ETV, and 4 patients we saw no flow void in the aqueduct was occluded, and only 2 patients we had a success. That's why our conclusion is that aqueductoplasty alone is not sufficient. Then ETV is much more effective. And the last technique I want to show you is an aqueductoplasty, which is combined with stenting. Usually we do it in isolated fourth ventricle. When we have just an aqueductal stenosis, we would prefer an ETV because we can avoid a foreign material. Trapped fourth ventricle, usually it's in children after shunting. Usually they are young kids. You see here, after shunt procedure, you see an occlusion of the aqueduct. We look in with our endoscope into the right ventricle. You see the cyclops ventricle. The septum is missing. One fornix is here, one fornix is there. And then you see it's very difficult to come in with this sharp edge. The trick is that we have an optical trocar, which has a conical shape, the tip. And this is introduced now into the endoscopic sheath of the lotoscope. And then you can dilate the foramen a little bit. and you can go into the third ventricle. You see mammillary bodies here. Here's the posterior commissure, and here you see the aqueduct. You see some hemosiderine residuals. That was the cause of the hydrocephalus, posthemorrhagic hydrocephalus. So we go in with our Fogetti into the aqueduct, but we do not dilate much. We just want to make an opening which is following the aqueduct. Then we can take again a 30-degree, 1.2 millimeter rigid scope to look whether we have reached the fourth ventricle. You see here rhomboid fossa, Luschke. So we go out and then we bring the stent in. The stent is simply a ventricular catheter which has side holes. So we bring it in through the working channel of the lotoscope. Then we remove the lotoscope over the stent. Then we remove the endoscopic sheath. And then we go in again with a 1.2 millimeter endoscope, and we follow the stent to check whether it's still in position or is there a dislocation while we removed the endoscopic sheath. But all is good. And then we connect it here to a borehole to avoid stent migration. And you see this is a stent in place connecting fourth ventricle, third ventricle, and lateral ventricle. So the conclusion is that for CSF pathway obstruction, so if there's an obstruction, there are several techniques available, and we prefer endoscopy to avoid shunt procedures if possible. ETV is gold standard for obstructive hydrocephalus. Aqueductoplasty without a stent fails frequently, so it's not recommended. And of course, there's a learning curve. But I recommend all of the young people to learn all these endoscopic techniques because it's really a benefit for the patient if you can avoid a shunt procedure. Thank you for your attention.
Thank you, Henry, for this wonderful presentation. There is any comments from the audience, from the panelists?
Everybody is convinced.
Yeah, it's convinced. My comment is that you give us some example of a flexible endoscope. I think for young people, they need a long training because with the cannula, with the straight endoscope is something that in stereotactic learning is easy to learn. Flexible is a little bit more difficult, and I think that is very useful, but you have to learn how to do it.
Yeah.
Another training, something like that.
That's correct. We use the flexible nowadays almost never, because aqueductoplasty is not a procedure of choice now in our hospital. And the problem is that the companies cannot get CE certification for the new videoscopes. You know, there's a very nice videoscope with a chip on the tip, what you use for tracheoscopy, bronchoscopy, but it's not allowed in the brain because it's not autoclavable. So in Germany, we cannot use it. And that's a pity because it gives really a nice, very nice view. The older ones you have seen a lot of pixels and the color or the visualization is not very good. Yeah, but the rigid one is much easier, no question.
Thank you. Any other?
Sorry. At
yes,
your
please,
convenience, Henry, please answer the question and on the chat and on the question. There are a few questions, you can do it after.
All right.
Okay, thank you again, Henry. If there is no other comments, I pass the chairmanship to Victor. Are you there?
He fall into sleep.
Fall to sleep, maybe.
Morning.
Yeah.
Victor, are you there?
It seems he is not there. Are you still going on your events?
Yeah, no, I can.
You can manage. Okay, so if you can continue.
After, no problem.
All right.
Okay.
Edward, are you there?
Yes, I'm here. You hear me?
Okay. Are you working? You stopped working?
Yes, unfortunately, I'm in between steps, but I hope I can squeeze this in. And I greatly appreciate that you have me. And I want to share my screen with everyone. And slideshow from the beginning. So, can everybody see my slide?
Yes.
Yes, it's up there. So I'm very happy that Henry gave an excellent introduction into this particular minimal invasive portion of our webinar. And I want to carry this one step further and briefly talk about a technique to make sure it doesn't get into obliviation. Because not everybody is familiar with endoscopy at the beginning of their career. And some of us may be already familiar with stereotactic techniques. And I want to offer a couple of pearls of most minimal invasive treatment for a similar problem.
Are you going to work?
Very technical, but requires a simple answer. So I have nothing to declare. I want to show you 3 scenarios where stereotactic treatment of CSF flow or cyst flow reestablishment can be chosen. One is unilateral hydrocephalus from entrapped temporal horn, as Henry had mentioned briefly. Then obstructive hydrocephalus from quadrigeminal plate arachnoidal cyst, and obstructive hydrocephalus from cavum vergae. I want to take you through clinical problems, conceptual problems, and the available treatment solutions. So first, let me briefly talk about, yes. So let me put the mask back on. I hope you can still hear me. So hydrocephalus in these cases occur secondary to lesions that obstruct the CSF flow. And it's usually somewhere in the atrium that the outflow obstruction occurs. And everything that is in the inferior portion, the temporal horn, continues choroid plexus and can create unilateral entrapment of the temporal horn with sort of focal hydrocephalus. These lesions can be neoplastic. We see that in cysticercus infections and some other tapeworms, inflammatory diseases, or hemorrhagic lesions. This is how 3 of these examples look. On the upper left, you see a meningioma of the atrium. On the upper right, you see a solitary fibrous tumor of the choroid plexus. You see a post-surgical hemorrhage, which can also happen spontaneously. And all these lesions have in common that you get a unilateral entrapped temporal horn, which may be symptomatic. So what is the clinical problem? There's stretch on the parenchyma of the meninges and the surrounding brain on the afflicted side, and it can compress Meyer's loop, the internal capsule, and the hippocampus. If it's a neoplastic problem, these patients often present late in their course of disease. And most common presentation actually is that the patient is just presenting with headaches, sometimes with ipsilateral tinnitus, but there may be contralateral hemianopia, contralateral hemiparesis, and on the left side, you often find a more prominent cognitive decline and even dysphagia. What are the treatment strategies we've heard about throughout the day? Well, you can do temporary external drainage if it's urgent, place an EVD, and then follow with open surgery to the actual pathology. And that would be preferred in many cases. You can do conventional shunting of the entrapped temporal horn, which is rarely done, but described in the literature. There's an interesting concept of frontal to temporal horn shunting, placing 2 catheters in the ipsilateral side and connect them by a U-tube so that you get equilibration of the entrapped temporal horn and the ipsilateral frontal horn. But you have to tunnel. It's similar to a shunt, though it's missing a valve. And you could go endoscopic and fenestrate the choroidal fissure, or, as Henry has shown, the suprachiasmatic cistern. But how about placing a lateral ventriculocysternostomy? So I want to show you this first and briefly talk about treatment constraints of the conventional options. If you place an EVD in open surgery, obviously you have 2 surgical interventions, which translates into higher morbidity. But if you can fix the primary neoplasm, that would be the way to go. If you place a shunt into the temporal horn, there's a chance of a device failure, which can be proximal at the level of the shunt valve or distally. And there's a risk of seeding if it's in a neoplastic case, let's say a metastasis to the choroid plexus. So I wouldn't prefer that. Frontal to temporal horn shunting has largely been abandoned because it's 2 surgical access sites and corridors, which increases your risk. And endoscopic choroidal fissure fenestration was nicely described by Andrew Perrin here from London, but carries a higher morbidity, and there's some risk for vascular injury and induced visual compromise and reclosure. So often people stay away from this. So what I want to propose is you can make your approach the least invasive and either do endoscopy, as Henry has shown, or you can do stereotactic intervention and aim for the highest quality of life with the most minimal invasive procedure, which I think is very helpful, especially in neoplastic and malignant disease. So this is my example, because I thought it would never come to a surgical intervention. This was a 41-year-old female patient who was diagnosed with meningiomatosis of the atypical version. She already had 4 prior craniotomies and did not want to have any further surgeries. When at surveillance MRI scans, she showed up with this tiny meningioma in the atrium of the right-sided lateral ventricle. She was a lawyer, had a KPS of 100, and was without focal deficits when we discovered this. So obviously, what would you do? We didn't do anything. We followed her sequentially. And to our surprise, a few months later, she presented with new onset headaches and a size progression, just 3 millimeters of this lesion, but it clearly had shown a ipsilateral and trapped temporal horn. So we still didn't know what to do because we didn't want to go through slit ventricles and explore this. So we first put on steroids. We thought maybe this is inflammatory. It didn't go away. And after 3 months, she came back and said, I want to get this treated, but I really don't want to have open surgery. So we decided to a stereotactic catheter placement for internal shunting. And although this may sound a technical overkill, I think it's a very safe procedure and someone who is familiar with stereotactic techniques. It gives you defined working trajectories. It is very short surgery, very short length of stay with minimal morbidity. And it's all about pre-surgical planning. So we do these cases in a fixed frame. I wouldn't do this freehand with the image guidance system only. We put the patient into a frame and measured the distance of the expected catheter from the entry point of the bone in the temporal squama to the prepontine cistern. If you get your angles right, you can place a single catheter that is pre-perforated and actually end up in the prepontine cistern, and the patient did stunningly well. And we then treated her meningioma post-operatively with stereotactic radiosurgery, which allowed us to have 2 minimal invasive procedures of 1 hour each with no morbidity. And the result was nice. After single fraction treatment of stereotactic radiosurgery to the meningioma showed complete local control, and the temporal horn had been successfully treated with our catheter implant. So from a legal risk perspective, in this case, she was a lawyer. She wanted to have minimal invasive surgery. We delivered, and I think this is a successful outcome. Conclusion, this approach takes advantage of the proximity of the temporal horn to the prepontine cistern. The topography gives you a near orthogonal trajectory to connect the 2 compartments. And if you come in from slightly posterior, your chances to hit Meyer's loop and create a major visual deficit is much less than with any other technique. It does obviate the need for endoscopic manipulation. It does not require multiple catheter placement as in the 2-shunt technique, and you don't need to tunnel anything subcutaneously. So it's a simple procedure, just with a lot of technology required. Second scenario, obstructive hydrocephalus from an arachnoidal cyst of the quadrigeminal plate. So an extraaxial lesion compressing the aqueduct. These arachnoidal cysts are very common. They are developmental abnormalities, and they present with some fluid that is trapped in the cystic structure. And for some odd reason, some of these arachnoidal cysts can grow like a valve mechanism. There's an ongoing debate how to treat them best, and you would only treat symptomatic lesions. And lesions can be associated with hydrocephalus in various locations. So the most frequent ones are suprasellar arachnoidal cysts. Then there are infratentorial arachnoidal cysts. And in this case, I want to show you a case of a quadrigeminal arachnoidal cyst with aqueductal obstruction. Again, there are three treatment strategies that come to mind. You can address the causative lesion and basically take care of the arachnoidal cyst through open surgery and fenestration of the cyst, which can be done microscopic or endoscopic with ventriculocystostomy or a cystocystostomy. You can also do focused shunting of the cyst, which is difficult in this location. You can symptomatically just treat the resulting hydrocephalus if a patient is not fit for surgery and do a conventional shunt or an ETV or any combination of the above. Again, there are treatment constraints. Endoscopic or open surgery has a high rate of closure and cyst recurrence. In the literature for arachnoidal cysts, the reclosure rate is almost 40%, although with better endoscopy techniques, I think the modern number may be much lower. VP shunt we talked about has device failure risks and infection risks. ETV, again, there are some procedural risk with a larger endoscopy access point here and reclosure. And combination surgeries carries higher morbidity. So here's my case. It's a 31-year-old female patient who is a circus artist. She was diagnosed with holocephalic migraines and an initial KPS of 90. She then developed nausea, vomiting, dizziness, and vision problems, and came into the ER in rather dire circumstances. So this patient went to the ER and showed this rather unusual but typical dumbbell-shaped arachnoidal cyst. We got a DWI on MRI scan to make sure it wasn't an epidermoid. And you can see how much mass effect is exerted on the aqueduct as well as on the fourth ventricle, and there's even a secondary Chiari. So she was diagnosed with a mixed supra and infratentorial cyst at the level of the incisura. Because she was in the ER and really not doing well, we decided to place a frontal EVD for emergent treatment, and opening pressure was 35. The headaches immediately resolved, and then we admitted her to the floor for further treatment planning. Now, normally, I would say this is a beautiful case of the P fossa, and I'm a fan of supracerebellar infratentorial approaches, but things are rather crowded at the back of the skull here. So open resection and fenestration may be challenging in this setting. And the same is, I think, true for endoscopic fenestrations. So the idea of internal shunting came to mind, which is not new. And there's an excellent paper by the group of Chris Ostertag that I show you in a second. So this is what we did for surgical planning. We planned this in 2 steps. We did a frame-based stereotactic cyst puncture first. Here you see the patient in the stereotactic frame. We aimed for the middle of the cyst, put a guide tube down from the top down, which is roughly the coronal suture, 2.5 centimeters to the side. And we then, afterwards, after we had achieved successful cyst aspiration and let's say 40% of aspiration, we placed an internal cystoventriculocystostomy shunt, which is again an internal stent used through a Holter catheter connected to a Rickham reservoir that the shunt doesn't migrate. So you can see, aspirate the cyst first, plan the trajectory, place the catheter in there, and then wait and watch and see what happens. And here you can see what happens. This is the ER presentation scan, 3 days post-surgery with the shunt, internal shunt in place. The arachnoidal cyst is already deflated, and at 18 months follow-up, there's near resolution of the arachnoidal cyst, and the patient was symptom-free. So the conclusion is there are many treatment options available for this condition, so why would you add another one? I think sometimes you have to pick the least invasive approach for the highest quality of life. She did not want to have a neck dissection from a posterior approach because she was an artist working with physical performances in the circus. I did not feel comfortable doing this endoscopically from the top down, so I thought this was a good approach, and I think it served the purpose. Last scenario, obstructive hydrocephalus from carbon vergae or septum pelludeum cysts. So this is a beautiful paper by my old group in Freiburg. Christoph Ostertag actually collected 26 midline congenital lesions and wrote them up in this paper in ACTA. This is the typical example I want to show you, a carbon vergae that is a developmental abnormality with ventricular dilatation by obstructing the foramen Monroy bilaterally. By placing a simple catheter through the frontal lobe, through the ventricle, into the carbon vergae, you can achieve decompression of the cyst, and the patient became symptom-free from headaches and seizure to nothing thereafter. In their paper, they described 27 such procedures, out of which 6 were carbon verruga and septopellutism cysts. They had an excellent success rate in their overall series and only minor complications. And I encourage everyone to read up on this, to have it available in your armamentarium as a minimal invasive procedure for a rare problem. So my conclusion is, for certain cases, less is more. We have learned from open surgery to go more to endoscopy. Sometimes we can go one step further and go from endoscopy to minimal invasive stereotactic catheter placement. And I hope this was a good example for you to keep this on your mind. Thank you very much.
Thank you to you. It was a really a very good presentation, and I think that your conclusion, do what is better for the patient and don't go ahead. Any comments? Questions? No one?
Good. I sign off for now.
I think I make a comment. I think that your mention of stereotactic approach is very important, because stereotactic it was overcome by endoscopy, it was overcome by neuronavigation, but still is a technique that can, in less cases that in advance, but it can be very, very useful. So thank you for that, and I thank you for your presentation again, and I hope to meet you personally. So there is the last question, the last lecture for Salam Sharif. Is Victor awake? Vladimir is there?
Yes, sir, but go ahead, Johnny.
Okay, thank you. I will not go the protagonist for the afternoon. So as a doorman, of course. Please, Salman Sharif, can you go ahead with the normal pressure hydrocephalus, etiology and management, please.
Thank you, Giovanni. I think it's a pleasure to be here, and it's wonderful to be among the friends again, and everybody most welcome. We have really enjoyed this over time, so I'm not going to waste my time and carry on. Pathway of CSF, everybody knows. And then we are talking about normal pressure hydrocephalus here. And if we are looking at where how the CSF flows, and then it goes down into the spinal canal, and also on top and gets absorbed from there. So the whole system is given here. The ventricular system is common and salient location for increased CSF content within the cranial vault. Hydrocephalus also encompasses.
Sorry, Salman, just 1 minute. Dr. Cohn, please mute yourself, Dr. Cohn. Dr. Cohn, mute yourself.
Please make mute everybody that is not the speaker.
Takashi.
The host can mute him.
You okay?
Okay.
So hydrocephalus. Sorry, Takashi. Thank you. Hydrocephalus increased CSF content in the extraventricular cranial subarachnoid space is also included in that. Ventriculomegaly, we know that increased CSF content in ventricular system. Subarachnoid hydrocephalus refers to increased CSF content in the cranial portion of the subarachnoid space. So what are the guidelines for probable intracranial normal pressure hydrocephalus, which is idiopathic, sorry. So criteria for probable idiopathic NPH, which were made in 2005, were insidious onset, age greater than 40, duration of 3 to 6 months, no prior event, brain imaging suggesting it, and it includes a requirement of Evans index of greater than 0.3, and evidence of periventricular signal change, and evidence of aqueductal or fourth ventricle flow void on MRI. Well, these guidelines changed in 2012, and Japanese and international guidelines were published then. And so the criteria of gait, cognitive impairment, and urinary incontinence came into play. Age above 60 or greater, ventricular dilatation by Evans greater than 0.3, exclusion of an alternative cause for hydrocephalus or alternative explanation for patient's clinical condition, normal CSF with opening pressure of 200 millimeter of water or less, disproportionate enlargement of subarachnoid hydrocephalus, which is called DASH, or on neuroimaging, and improvement of symptoms after CSF tap, and then DASH details, and I will show that later. So let's talk about the three etiological factors: congenital, CSF fluid absorption impairment, and vascular risk factors. So why do we think it could be congenital? Persons diagnosed with NPH have a higher head size in more than 10% of cases. There are association of cerebral aqueduct stenosis, common causes of hydrocephalus in young. Symptoms may not manifest until adulthood. You could have a syndrome of long-standing overt ventriculomegaly in adults, which is lower, and clinical presentation similar to NPH, like dementia, gait disturbance, and urinary incontinence due to various other causes as well. So secondary NPH may be suspected if you've got a large head size, you've got a dry ventriculomegaly without involvement of fourth with T2 signal change, and evidence of aqueductal stenosis or webbing with special MRI sequences. So a form of a communicating hydrocephalus with insidious onset, that's what we talk about NPH. So primary, without a cause; secondary, post-infectious, inflammatory, or hemorrhagic following a subarachnoid hemorrhage. So impaired CSF absorption mechanism is poorly understood. There are different etiologies depending on the CSF dynamics. Is there a production or flow or absorption problem? The endpoint is obviously finally when you get increased pressure, the ventricles dilate. But once the ventricles dilate, the pressure comes down. So that's why it's called normal pressure hydrocephalus. Anyway, that's the theory about it. So if you've got a patient who's got atrophy, you're going to have no communication going through, whereas interstitial fluid leaking through. So you can see the superior sagittal sinus coming through and having no fluids, whereas excessive fluid is secreted here. So this is the difference between NPH and atrophy. Vascular risk factors. It's been shown in ARIC study, which was atherosclerotic risk study, showing that pulse pressure and baseline systolic blood pressure was associated with enlargement of ventricles. Why NPH is difficult to diagnose and manage? There are so many questions regarding that. So characteristics of NPH, common in elderly, we've talked about it. Gait occurs in 20% in age 75, is associated with dementia. Incontinence, normally you get in 38% of women and 18% of men at that age. Dementia, normally you get 14% of those people who are above 70 anyway. So diagnostic tests for NPH, there are false positive and false negative. And you can have overlying conditions like Alzheimer's, Parkinson's, spinal stenosis, large joint diseases, or neuropathy of various kinds. So what about clinical features? Insidious progressive gait syndrome, urinary urgency followed by incontinence, cognitive impairment. So if you've got periventricular, frontal cortical, basal ganglia, thalamocortical circulatory impairment in the setting of CSF hypervolemia, then obviously you may get exactly the same clinical condition. So there could be this theory about having a hypometabolism in the caudate nucleus. And so, for example, this picture showing on the PET itself that the caudate nucleus itself could have, which is striatum, could have a hypometabolism and can give rise to similar features as well. Gait dysfunction, apraxia, magnetic or glued-footed gait, which could be secondary to a problem down in midbrain itself or brainstem, sorry. Highly variable thalamocortical circulatory disruption. So you have small steps, wide base, difficulty with turns, and postural instability. So you need to exclude gait dysfunction secondary to spinal problems, peripheral neuropathy, cerebellar disease, visual, vestibular function, substance abuse, alcoholism, which is quite common. Cognitive impairment, there is psychomotor slowing, there is decreased attention and concentration, impaired executive function. So you can't do those executive functions. There's apathy, anomia, there is cortical neurodegeneration disease, and that's typical of Alzheimer's. So that's how you differentiate between Alzheimer's and NPH directly. What about urinary incontinence? So you get typical frontal lobe incontinence in which you get urgency, frequency, and eventually urgency incontinence. So how do we diagnose NPH? So you screen for overlapping disease, you do diagnostic tests. So for example, characteristic history, we talked about it. 2 or more years of cognitive decline before presentation, then it's poor prognosis with shunting, that's more than 2 years. Alcohol abuse, poor prognosis as well. History of fall, strong indication to intervene, very good results of these patients. Urinary difficulty, type, how long? Urgency is most common problem. Incontinence is not necessary for diagnosis. So diagnostic modalities, MRI, LP, external lumbar drainage, and CSF biomarkers. So let's look at MRI. Evans ratio, we talked about that if the ratio is 0.3 more, then you consider NPH. Colossal ratio, which is now routinely used as well. So you've got those 2 coronal angles coming down, and if your ratio goes less than 90, then you think about NPH. Normally it is above 100 to 120. In true communicating hydrocephalus, CSF has the potential to increase volume not only in ventricular system, but also in the communicating subarachnoid space. So you're going to see collection in the major fissures, and you'd have compressed areas of adjacent sulci, just like this here. So you've got all these tight sulci on the top that you see, which are typical of NPH. So you have the 3 things that are seen here: tight, high convexity. You've got enlarged sylvian fissure, and you've got ventriculomegaly. So it's good response to shunting or diversion procedure of some kind. What about fluid collection in an anterior and posterior aspect of the sylvian fissure, which is shown on both sides? And you'd have fluid pockets in there, but these sulci are really tight, suggesting a problem. So this may be mistaken for atrophy, but it's not. It's typical of NPH. Same thing we can see on 3 images. So you've got the 3 images of the sylvian fissure itself, showing that the middle, the anterior and the posterior aspect, and how much of enlargement you see. And on the top, you'd see that sulci are really tight. Besides that, you're going to see some pockets of fluid accumulation. This another sign is very typical. So you've got this third ventricle, which is parallel or bow outward in NPH, whereas normally, obviously, you see it slit or go up and down. So this is a typical finding of NPH itself as well. High volume tap, we need to know that CSF is made at the rate of 0.3 mil per minute. So therefore, after 3 hours, the CSF withdrawn has been replaced. So it's important to know that, that any test you do within that time. So videotape patient's gait before, and then videotape patient's gait 30 minutes after. And if it's improvement in gait, obviously, then very good prognosis. 3 measures that we look at: time taken to walk 10 meters, 180 degrees, turn to starting point. Number of steps needed to turn 180 degrees, and number of steps needed to turn 360 degrees, 3-time average. So these are the measures to see the gait improvement. Some people used to use external lumbar drain, but because of problems with false negative and meningitis, we stopped using this. Biomarkers, a lot of people are using these biomarkers, and you can differentiate between Alzheimer's and NPH with these tau genes, P and T, and these 2 would be elevated in Alzheimer's, whereas in NPH, they all are low. In NPH, the typical range of metabolic products is impaired, so we're talking about those proteins, resulting in many proteins being low when measured in CSF patients with NPH. And they become normal when the shunt is placed and all those proteins are taken away from the brain. Surgical consideration: adjustable shunts, they've shown to have a better outcome compared to fixed shunts because of the risk of subdural hygromas or subdural hematomas. And if you see here, complications, this is till 2010, and looking at about 30 studies, looking at 1,500 patients. So you've got subdural hematoma of 5% with intracranial hemorrhage of 0.2 and revision in 13% of these patients. Setting the opening valve pressure, the important thing is that you set the valve pressure at the LP opening pressure. So if you're going to go lower than that, you can cause subdurals to develop. Endoscopic third ventriculostomy. It was just shown by Henry beautifully. Allows CSF diversion, not going to go into this. Restoration of cerebral pulsatile effectiveness. So does it work? So average success of ETV in treatment of NPH has been estimated to be as high as 61%. At the same time, average reported complication is 5% and reoperation 30% of these patients. So this study from Italy showed improvement in 70% of their patients with no change in 20% and continued deterioration in 1 in 10 patients. So this is a video. I'm actually not going to go into detail of this because Henry's already talked about it. So the usual thing, I usually use this bipolar to make an opening and the usual thing that we do. So data at our center studied with follow-up of minimum 6 months of 20 patients showed that these gait disturbance 70% and improvement, 20% up to grade 2, urinary 50%, and dementia up to 50% upgraded. So how to evaluate these improvements? So there's a scale, and it's a 0 to 100 point scale, which looks at gait, cognition, balance, and urine control. So for gait, we look at the time taken for various things, which I talked about earlier. For balance, we look at, are you able to stand independently? And there is an ordinal rating is given, just like the gait one as well. And then incontinence scale of NPH, which starting from normal, from urgency, going all the way to incontinence of bladder and bowel both. Cognitive scale, there are other Swedish group scale. You've got the Ray auditory verbal test itself and the grooved pegboard test. There are many mental examination is simple to do. Videotaping, we talked about it. So the take-home message for NPH, it's rare but treatable disease of elderly. Diagnosis is difficult because many diseases can cause cognitive impairment, incontinence, and gait dysfunction in this particular age group. Surgical intervention in selected patients can result in clinical improvement, but the risk of shunting and overdrainage are still there. Neuroimaging features of NPH, which are amazing now, have allowed improved identification and selection of patients with NPH. And I bring greetings from Pakistan. It was really a pleasure to be here with you guys.
Thank you. Wonderful presentation. Any comments?
I have a question.
Yes, please.
Thank you for the great talk. Do you think ETV is a good indication for NPH?
What we did was we did this study looking at specifically, and of the 20 patients we operated, 2 of them we had to put in a shunt. And now our follow-up is over a year, and rest of them are doing well at the moment. And we continue to follow them very closely, and we will see. There are multiple studies from various centers. The idea behind ETV is that you probably buy, if it's done early, and if you do ETV, then you buy, then you could have up to 2 to 3 years of good time. And 70% of them will be well in the long term. And if that is the case, it is a possibility that you may avoid shunt during that time and the risk of overdrainage, etc. So if you can take away that risk, and if you can improve their outcome in 70% of patients, I think it's probably a reasonable option.
That's interesting. Our experience is not as good.
Yeah.
Andre, what do you think? I think we have, most of them have received a shunt.
Yeah, but I can say that initially, it is a subgroup. I have seen patients, what I call the kind of functional aqueductal stenosis. Typically, they had, they were, let's say, in their 60s, they had these walking difficulties. We do lumbar infusion test, computerized. And then this was just at the edge. And they had typically a smaller fourth ventricle and larger third and laterals. So I did some ETVs, and also especially because I was good friends with Michelangelo Ganghemi from Naples, who unfortunately died not so long ago. And he was experienced in that, but he also recognized that there's a subgroup, and we simply can't can't really diagnose them well. And I have to say my overall, because initially in the 90s, I did ETV for everyone with hydrocephalus and for all MPH patients also as the first procedure. And that result was bad. So my result for ETV, I think overall what I did in MPH was less than 20%. But I think there was, and oddly enough, I remember even the mother of my personal secretary, she had an MPH and I did an ETV and she was very well for about 8 months. And then she started to decline again. Of course, and they said her husband died from leukemia. So there were all other reasons. But we gave her a shunt and she was much better, much better. So for me, judge is still out. I'm not very convinced, to be honest. So I will not offer it as a choice.
I have a question.
Yeah, can I just answer that? What we do is patients who present to us early, and if their history is primarily of dementia and gait, those are the ones that we are selecting for this. And for example, if somebody's duration is only 6 months or less, then their outcome with ETV at the moment is very good. So both the patients who were operated after a year required a shunt, and for those who had a short duration, are doing pretty well with ETV.
Maybe.
Can I make a comment, Himad?
Sure.
May get into the discussion. I was the one that was signed the paper of Gajemi that you mentioned. Most of our patients has to be shunted later on. So I think that there is subgroup. The question that I do to all of you is worth to do dynamic of CSF to make a better diagnosis and to choose in between the different group?
Well, we use the this Liquoceldar system, the computerized lumbar infusion test, and when there is the resistance to outflow is clearly high. And after then, because you can also at the end you do a TAP test, and we have this computerized walking test. So they walk on a line, and that is measured. The step lengths and the step weight, it's all measured. And if that really clearly improves, we think they are good candidates for shunt.
For shunt, not ETV.
No, not ETV, because we don't. I see only little people with these what I would say that is not MPH. That is obstructive hydrocephalus of an adult. And that's the problem, because they have normal fourth ventricles and then still, let's say, at least a flow void in the aqueduct, but large third, even sometimes a bulging floor of the third. Okay, then I would consider ETV. But in all these others that are sent, and I have to say that also with the shunting, not everyone, even with these tests, they initially all improve somewhat, and that is also the placebo effect of what we do and what we talk with them and the family who is enthusiastic, and then, but the end result of the shunting was overall much better than those where I decided to do an ETV. Initially, some were well, and we say, wow, we avoided the shunt, but they had to come back. They had to come back.
Yeah, Andre, we have exactly the same experience. And I think the few patients which are long-term good, they are really obstructive hydrocephalus. They have these membranes in front of the brainstem, or they have a functional aqueductal stenosis. So Salman, we want to see all 20 MR images before and after.
Okay, then no worries. You will have them.
Giovanni, may I have some
Sorry, there is Imad.
Actually, I want to ask all of you, because I'm handling a case just the past 2 weeks with this issue. That's why I like the subject. I want to concur with Henry what he's saying. The definition you gave, Salman, and this is my understanding, normal pressure hydrocephalus is problem with absorption. How you will find that fenestration will be solving the problem with absorption, unless there is some element, as Andre said, there is an element of not vested hydrocephalus, but an adult hydrocephalus with aqueduct stenosis. These are the cases benefit from the shunting, not the other one.
Yeah. Well, Imad, I have to say that because it is invasive, it is not so easy, but we have done 5 patients with a telemetric intracranial pressure measurement. They were already candidates for either ETV or mostly, let's say, shunt, and we placed a telemetric pressure measurement. Oddly enough, those 5 patients had, we call it normal pressure hydrocephalus, but they had elevated pressures at night. So I doubt that they are all, we did already all the tests, the lumbar infusion test, we considered them being the MPH, the candidate for shunt, and then we placed a telemetric pressure monitor. And for well, a maximum of 30 days is allowed officially, although we had some with much longer. But and then we found out that they have elevated pressure, prolonged periods of that during night. So I think.
I have one thing on the history of this patient I'm dealing with. When I went back to his old images 12 years ago, he did have triventricular megaly and some element of aqueduct stenosis, no other symptoms, and he was asymptomatic, without gait problem, without urinary problem. Now, 6 months ago, he started having this. The ventricle size and the appearance radiologically almost the same, even we did the flow, is the same. But he got the new symptoms. Is it decompensated previously arrested hydrocephalus most probably?
Yeah,
Like he will benefit from defenestration rather than is a pure normal pressure hydrocephalus.
Yeah, I think so. Yeah. Therefore, I think there is a mix-up. There is MPH, but I think we have also adults in older age. Difficult for me to say older age if it is your own age, but in that period, you still can have a kind of obstructive problem in your CSF circulation.
Yeah.
So I think because of the age,
yes,
we always say that it is MPH, but it's not always. So somebody over 60 or 65 can also have something else.
Imad, may I make a comment?
Yeah, Modi wants to give some.
I think the Japanese have put in a very interesting and strict criteria through the Japanese Committee for Scientific Research, and they grade them according to their gait disturbance, dementia, urinary incontinence. From 0 to 4, for example, in gait disturbance, normal gait is 0, unstable but independent is 1, walking with 1 cane is 2, walking with 2 sticks or a frame is 3, unable to walk is 4. Similarly for dementia, 0 to 4, urinary incontinence, 0 to 4, that means 0, no incontinence, 4, totally incontinent. And what they have suggested is that in selected cases of MPH, mainly with a short duration of symptoms of no more than 6 months, ETV can provide good results. And in terms of the indications, as opposed to Salman, who operated on patients who had demented, it says their feeling is that short preoperative evaluation, a significant prevalence of gait disturbance, and little or no dementia, these are the selected cases that might benefit. So I think there is a role, but one needs to understand it much more closely and select your patients. I think that's what the message is from the Japanese
group. It is all about selection, Modi. I fully agree with that. The thing is that the last patient they had with a pineal lesion, he was 59, so not 59 years old, had hydrocephalus, but the presenting symptoms were short-term memory deficit, gait disturbance, and urine incontinence.
So that was obstructive.
It was an obstructive hydrocephalus, but the symptoms were still this. So in the adults, typically, they don't vomit. They don't say morning headache like we see in the kids. In an elderly adult, if they have even a clear-cut obstructive hydrocephalus, the prominent symptoms are memory problems, gait difficulties, and urine incontinence. Actually, for the last one, in such patients, you have to ask for them because they already are visiting a urologist for 2 years, but they never relate that themselves to it. But really, so we cannot only use those symptoms to classify and say it is an MPH. Not only. We need more. Henry.
Yeah, I completely agree, Andre. I think these symptoms, these Hakim trias, this is a sign of chronic hydrocephalus, and you can see it in obstructive and you can see it in NPH. Absolutely. And Imad, your case is probably a late onset hydrocephalus, and I think it's a good chance that he will profit from ETV. So we had several patients of these, even some we observed over the years, and then they deteriorated later.
Yeah. Because this was a benign pineal lesion, and then we did indeed an ETV, and just are watching now the pineal lesion because it was benign. We did a biopsy, and it was just a pineocytoma. I mean, you don't have to do anything about it. And the hydrocephalus, but still, I only wanted to mention the symptoms were exactly the same as I see. We have an own adult hydrocephalus clinic. So they sent them from everywhere in our country. We have a special clinic on Wednesday afternoon only for adult hydrocephalus. And therefore they send them. And we see numerous of them. And of course, sometimes we see also patients who have atrophy, who clearly have severe dementia and no gait disturbance and no urine incontinence and large ventricles with huge atrophy. We see all of them. So we start to, and then we found out that it is difficult to just based on these three trias of symptoms to say this must be an MPH, because usually we say that because of the age. And I'm now reluctant to do that.
So before I give the podium to Giovanni to conclude the talks and to Vladimir to conclude the session, I think we did a bit over time. Can we, for the sake of the attendees and trainees, give a consensus that in such cases, you can still come with the third ventriculostomy as a first step, and then if it did not work, then you go for the shunting, or you will go for the shunting?
I personally would go for shunting, but we have currently a prospective randomized trial in our department. So maybe in a few months or years, I can tell you what
give us.
That would be wonderful.
No, I think that in the meantime, for the young people, you can make belt and suspenders. So make the ATV and put a catheter with an Omaya in the hole, so eventually the shunting will be easier. No brain insult again. So I think that this session was very good. CSF problem from this history till the therapy is very important. Personally, I have some interest of what is going my personal CSF fluid because I'm aging, and so I think that will be the pathology for the future, because in all country, let's say in the Western or white country, this aging is bringing a new pathology. And
we don't want to leave our heads in the hands of these guys. Their hands are itching.
And we have a very good vision of what is the frontier in some country of the small children fenestrated hydrocephalus and all this pathology. So I thank you again, all the participants, all the lecture was excellent. I hope that young people learn a lot of this webinar. I hope that this is the last one because we can meet personally. Otherwise, we continue. Okay, Vladimir.
Vladimir is Yeah.
Dr. Ahmad, thank you so much. And dear friends, dear colleagues, this was a wonderful lecture about hydrocephalus that is very common until date. So I think this was very important for young brain surgeons and also for expertise. So thank you so much. Tomorrow we will continue. Thank you, Dr. Ahmad.
Thank you. Vladimir, you want to give your final statement?
It was excellent today. The older guys probably remember Fleming Bieris from Copenhagen.
Absolutely.
Who used to be the president of the ANS. Yes. And he always had a lecture, which was, but if you compare what he was saying at the time and what we are now able to do, it's extraordinary progress. And I believe, Johnny, that we both can be safe with our shunts, which are coming soon. That's all. See you tomorrow.
Okay. Tomorrow we'll have a vascular session, and it'll be an exciting program with a few colleagues, invited colleagues, and members of the committee. I wish you all a restful evening and have a safe trip with Giovanni. It looks like you're packing, and take care of yourself and your family.
Okay.
Okay.
Bye-bye.
Bye-bye.
Bye, Moody.
Bye, Pablo.
Bye. Thank Pablo.
Thank you,
as
Matt.
usual.
See you tomorrow. Rames,
See you tomorrow.
Dr. Kirolo is here. Yeah. How are you?
Yeah.
Yeah.
Hasta mañana, Víctor.
Bye.
Hasta mañana, querido.